Professor and HOD, Department of Pediatrics, Mysore Medical College, Mysuru. I request Dr. Komala and Professor of Human Development and webinar convener, in Food Science and Nutrition, University of Mysore, Mysuru, to introduce the resource person and moderate the fourth scientific session of the webinar. Over to you, Dr. Komala and Madam.
Good morning to all. I am very pleased to moderate the fourth scientific session of the webinar, Management of Low Birth Weight and Premature Babies. As you all are aware, birth weight is a good reflector of a status of maternal health. It is also true that birth weight is the single most important factor that affects neonatal mortality and morbidity as well as of infant and child morbidity. In an inaugural session, the Professor Hemant Kumar, the Honorable Vice Chancellor of University of Mysore, mentioned that India is contributing to highest number of neonatal deaths, low birth weight, premature birth in the world. Worldwide, 1 in 5 babies born with low birth weight and 1 in 10 babies born preterm. According to WHO, every year around 15 million babies are born preterm and nearly 15% of babies are born with low birth weight. And India tops the list of 10 nations contributing for low birth and premature babies. Of the low birth weight and premature babies, small for gestational age neonates remains the cause of concern and given their long-term consequences in developing countries including India. Prevention and management of low birth weight and premature babies presents several great challenges. Dr. Sudha Rudrappa from Mysore Medical College, Mysore, is a competent person to address the issue related to low birth weight and preterm. I'm honored to introduce the speaker of this scientific session, Dr. Sudha Rudrappa, to you all. Dr. Sudha Rudrappa is working as the professor and head of the Department of Pediatrics, Mysore Medical College and Research Institute, Mysore. She has a vast teaching experience of 28 years and she is also serving as a faculty of ACIR Integrated MSc PhD program at CFTRI and discharging the duties as an examiner for PG as well as of UG program at Rajiv Gandhi University of Health Sciences, Karnataka, the Tamil Nadu Dr. MGR Medical University, Kerala University of Health Sciences at various other universities. Dr. Sudha Rudrappa has been actively involved as a faculty at various state level, national level conferences. She was president of IAP, that is Indian Association of Pediatrics, Mysore District Branch during 2016, and even she worked as the South Zone IAP PG Quiz Coordinator. Dr. Sudha Rudrappa had published about 40 publications in both national and international journals. With this brief introduction, I invite Dr. Sudha Rudrappa to deliver a talk on management of low birth weight and premature babies. Over to Dr. Sudha Rudrappa. Thank you.
Ma'am, you are not audible.
Thank you, madam.
Ma'am, we can't hear you, ma'am.
Hello.
Yes, ma'am. We can hear you now. Thank you.
Hello. Hello, sir.
We can hear you, ma'am, now.
Okay then.
Thank you, ma'am.
Thank you, madam, for this kind introduction. I must thank the Department of Food and Science Nutrition, University of Mysore, for giving me an opportunity to speak on management of low birth weight and term babies. I would be introducing this talk with this. I would be just telling briefly about the few terminologies, what we use, the incidence of preterm and low birth weight in India and over the world. What are the causes of preterm and low birth weight babies? Regarding the nutrition in pregnancy, what are the characteristics of preterm and low birth weight babies? And how do we care a
She has
preterm
to.
baby? Complications and prevention. So
The
before we
PPT
go
is
to
not
what is
visible.
hello,
Excuse me, ma'am. The PPT is not visible.
PPT not visible.
Share the screen, ma'am.
Shake the screen. Now, sir. Now,
No, ma'am. Still not visible. Yes, ma'am. Now we can see.
now you can see.
Slide. Yeah. Yes,
Shall I
ma'am. It's
continue?
visible now. Yes, ma'am.
Shall I continue, sir?
Yes, ma'am. Continue, ma'am.
Okay. So, sorry for the
Excuse me,
interruption.
ma'am. Ma'am, will you please start from the first one, please?
Okay. Start from the
Thank
first.
you.
Good morning, everybody. I thank the University of Mysore for giving me an opportunity to talk about management of preterm and low birth weight babies. Now, as you all know, pardon, I would be.
Yes, ma'am.
Hello.
Yes, ma'am.
Can I continue?
Yes, ma'am. Continue, ma'am. Ma'am, please lower your camera. That's it, ma'am.
Pardon?
Lower your camera.
Okay. Lower your camera.
Yes.
Dim the camera.
Your camera, ma'am. Yeah. Yeah, fine, ma'am.
Now it's fine.
Now it's fine.
Now it's fine.
Thank you. Thank you.
Continue. Thank you.
Okay. So now, regarding the management of low birth weight and preterm babies. First, we should know what is the terminologies, incidence, causes of preterm and low birth weight babies, nutrition in pregnancy, general characteristics of a preterm and a low birth weight, and how do we care a preterm baby, what are the complications, and how do we prevent them. Before we go to what, we should know something about fetal growth. Embryo is nothing but it is up to 8 weeks is called a embryo. Fetus is up to 12 weeks. Fetus is at 12 weeks and it goes up to 40 weeks. And once the baby is born, then it is called a neonate. Any baby born before 36 weeks of gestation is called preterm. And then you have late preterm and a term baby. This is the usual definition of a term baby. Preterm baby born before 37 weeks of gestation, irrespective of birth weight, are called preterm neonates. And again, these preterm have been subdivided: extremely preterm, very preterm, moderate preterm, late preterm, based on the gestational age at which the babies are delivered, because we should know all this as so as to mark the prognosis and the risk factors which are there have to be treated, and so as to avoid the morbidity or mortality in the due course. 34 weeks marks as an obstetrical mile after which antenatal steroids are not administered. Next, terminology for variation in fetal growth. The birth weight is first recorded. Preferably, we record within 1 hour of life. We can measure up to 24 hours. Normally, as you all know, it is weight of the normal newborn baby is more than 2,500 grams. Low birth weight less than 2,500 gram. Very low birth less than weight less than 1,500 gram, and extremely low birth weight less than 1,000 grams. So low birth weight, why we should know all this? The prognosis, the mortality, morbidity has to be predicted. So that is the reason the low birth weight has been divided into very low birth weight and extremely low birth weight. The other terminology which we should know is intrauterine growth restriction. This year, the rate of fetal growth is less than normal for the population and for growth potential of specific neonate. What happens? This is again subdivided into an asymmetrical IUGR and a symmetric IUGR. The symmetric IUGR babies have both brain and body growth are affected, and the prognosis is not that good. In an asymmetric IUGR, the brain's growth is spared. That is why the long-term prognosis is good in a asymmetric IUGR babies. The incidence of is around 15 million babies are born too early every year, which is more than 1 in 10 babies. Approximately 1 million children die each year due to complications of preterm birth. Globally, prematurity is the leading cause of death in children under the age of 5 years. 3/4 of these deaths could be prevented with the current cost-effective interventions. Across 184 countries, the rate of preterm birth ranges from 5% to 18% of the babies born. In India, out of 26 million live births annually, 3.5 million are preterm, and out of these, 3.03 lakh babies die due to complications of preterm birth. Majority of the countries show an increase in the preterm birth rate over past 20 years owing to increase in the maternal age, maternal health issues, and infertility treatment. It is mainly, as we are seeing in the modern era, uh, because of the increase in the infertility treatment and other issues, we see these days more of preterm birth rate. About 10 to 12% of Indian babies are born preterm as compared to 5 to 7% incidence in the West. Babies born preterm and low birth weight is one of the leading cause of neonatal mortality. The incidence of prematurity in India is 12.8%, and the long-term disability with these preterm babies are around 3 to 4-fold high, and they are at risk for poor child survival. Hence, prevention of low birth weight should be one of the nation's top priorities. As per the SRS 2018 statistics, the neonatal mortality rate of is around 816 per thousand live births, and by 2030, the India plans to achieve a single digit should be a single digit mortality, and under 5 mortality as per 2018 statistics is around India is 32, Karnataka is 28. But what was there in 2009 or 8, it was around 50, 45. Now we have reached up to 32 is the IMR. Coming to next, what are the causes of prematurity? It can be either spontaneous or induced. Spontaneous, like maternal infections, like cervical incompetence, any chromosomal disorders. In the maternal, it's mainly what we see is the age, height, short pregnancy interval, poor weight gain, associated illness in the mothers, placental disorders, and in the environmental, it's assisted reproductive technology and the substance abuse. And sometimes we also see these days with the food taboos and teratogen exposures. Next, what are the risk factors for low birth weight babies? It could be again divided into demographic, pre-pregnancy, pregnancy, and behavioral. Demographic, like low socioeconomic status, pre-pregnancy, short stature, if there is chronic medical illness as discussed earlier, poor nutrition in the mother, parity, and any uterine and cervical anomalies, mother having anemia in pregnancy, associated preeclampsia, infections, and substance abuse and stress. Actually, the adequate weight gain should be around 9 to 11 kgs in the pregnancy. Now, what is the first 1,000 days nutrition that matters? The first 1,000 days, it's from the birth till 2 years of age. In the first trimester, because of this increased oxygen demand and increased blood volume and the neural growth, mainly folate, iodine, and vitamin D are required. In the second trimester, increase in the cardiac output and increase hormonal level and decrease insulin sensitivity. You have to supplement carotenoids, folate, iron, and omega-3. In the third trimester, there will be calcium absorption, increase in the plasma volume. So thereby, these and the micronutrients are transferred from the mother to the baby, and the demand is more. So we have to supplement along with calcium, carotenoids, omega-3, vitamin D, iodine, and iron. So it is 280 days. Once the baby is born and it is up to 2 years, baby mother has to breastfeed the baby, and there'll be risk of depression and changing in the hormones. So in the postpartum period, the mother should be given calcium, choline, folate, iron, and omega-3 along with vitamin D. Initially at birth, the growth of the brain is complete by around 50%, and remaining 45% of the brain growth will take place up to 2 years. So that is why this nutrition is important. One has to concentrate mainly on the first 1,000 days, especially in the in the 9 months of pregnancy. What is mother-child environmental relationship? Here, if the mother is a chronically malnourished pregnant woman, she can deliver a low birth weight baby, and in consequences, they can have malnutrition and infection in adolescence and infancy, thereby leading to stunted adult, reduced work output, impaired learning ability, poverty, and it's again a chronic malnutrition. So it is almost like a vicious cycle. So early intervention at the grassroots level regarding the nutrition of the pregnant lady would prevent all these morbidities. Eating right during pregnancy. It is keeping a healthy lifestyle throughout pregnancy as well as before and after. So, as you all know, balanced diet, right amount of weight gain, which I already told you, 9 to 11 kg, light, regular physical activity, taking vitamin and mineral supplement, and avoiding substance abuse. In the first 3 months, you all know it's the folic acid which is supplemented, and in the last 6 months, we give iron, folic acid along with calcium, and the normal balanced diet. The calories required are in pregnancy, it is around 2200 to 2500 kilocalories uh, on an average, and extra 350 kilocalories. And in during lactation, it is in the 6 months we give add around 600 kilocalories, and 6 to 12 months we give an additional of 520 kilocalories. This is a slide showing about the nutritional requirement during lactation. Vitamin A, B6, B12, folic acid, and vitamin C. Vitamin A, 950 microgram per day is required because breast milk as such is rich in vitamin A. So lactating mothers need adequate amount of vitamin A in their diet. Similarly, other like B6, B12, folic acid, and vitamin C also should be is required during lactation, and diet rich in this should be supplemented. General features of a preterm baby. The crown heel length is around less than 47 centimeter. Looking at the baby, we can say it's a preterm or a term. Head circumference will be small. Activity of the baby is poor. The reflexes will be incomplete or sluggish. Baby assumes an extended posture or due to poor tone. Very little care, vernix caseosa. The subcutaneous fat is deficient in this preterm babies. Characteristics of an intrauterine growth restriction, which I told earlier. Symmetric and asymmetric. Symmetric is early onset and it is constitutional or normal small baby. They have a low biophysical profile and decreased growth potential in a symmetric IUGR, whereas growth arrest in a asymmetric IUGR, and that can occur in the late trimester, late onset. Brain sparing effect. Examples for asymmetric IUGR can be a preeclampsia, mothers who had preeclampsia, poor calorie intake, mother having chronic hypertension, diabetes in pregnancy. In a symmetric IUGR could be a genetic cause or torch infection, that is intrauterine infection like toxoplasmosis, rubella, cytomegalovirus, herpes, etc. What are the physiological handicap of a preterm baby? Central nervous system. We go system wise. Because of the immaturity of the central nervous system, it is expressed as inactivity, lethargy, poor cough reflex, incoordinated sucking and swallowing. Because of the immature blood vessels, there is increased risk of intraventricular hemorrhage, periventricular leukomalacia. They can have intracranial bleed. Sometimes resuscitation at difficulty occurs at birth because of inefficient blood-brain barrier, and these babies are also prone for retinopathy of prematurity, and other problems which I'll discuss in the future slides. Thermoregulation. These babies, I already told you, they are prone for hypothermia due to increased heat loss through immature skin and due to paucity of brown fat compared to a term baby. Nutrition, due to the decreased stores of iron, calcium, vitamin E, folic acid, it leads to increased risk of anemia, thrombocytopenia, and edema at 6 to 10 weeks of life. Respiratory system, these babies are prone to respiratory distress syndrome because of associated with deficiency of pulmonary surfactant. There could be pulmonary aspiration and atelectasis. They are also vulnerable to develop chronic pulmonary insufficiency due to bronchopulmonary dysplasia, cardiovascular system, patent ductus arteriosus. They'll be the closure of the ductus takes a long time in a preterm, whereas in the term it closes within 24 hours after birth. Gastrointestinal, these babies have common problem of regurgitation and aspiration because of incoordinated sucking, small capacity of the stomach, gastroesophageal reflux disease is common. These babies are prone to neonatal necrotizing enterocolitis. They have the risk of hyperbilirubinemia due to immature enzyme, increased RBC breakdown, and increased enterohepatic circulation. Because of low, poor hepatic glycogen stores, delayed feeding, birth asphyxia, and respiratory distress syndrome, these contribute to development of hypoglycemia in the preterm babies. Now, let us go on to how do we take care of these preterm babies. Whether it is a term, or preterm, or a low birth weight, mainly the hygiene, personal hygiene is more important. Before touching the baby, whether it is at home or hospital or institution, hand hygiene is most important. This shows us the 7 steps as to hand washing. Hand rub, the whole procedure is within a minute. Hand rub is 30 seconds and the remaining should be done within a remaining steps should be done within a minute. So hand hygiene is most important before we handle the baby. So what do we look for? Management at birth. Delay in cord clamping, it helps to improve the iron stores of the baby. The baby should be promptly dried, kept effectively covered and warm. And as you all know, vitamin K 1 milligram should be administered intramuscularly, and gentle ventilation to be done. That is TP resuscitation, constant delivery of peak to avoid hyperventilation and hyperoxia. You have to keep the target at 85 to 95% at 10 minutes after birth. Once the baby is born, we obtain the weight. Daily weight assessment indicates a hydration status of the baby. As you all know, the term babies, whether term or preterm, tend to lose the weight. They gain the normal weight in a term baby by around 10th day of life. In the preterm, it is around by 15th day of life. We have to, because if the weight loss is more, then we have to see whether the fluid administration is correct or any other co-infection that baby might have developed. So that is the reason the weight assessment should be done. Then I already told you baby develops RDS, so the surfactant administration, secure an IV line, adequate hydration, so limit evaporate water loss, humidified incubator, skin care, and ventilation to be given. What are the cost-effective management of preterm babies? One is KMC, otherwise called Kangaroo mother care, delayed cord clamping, providing warmth, exclusive breastfeeding, and vitamin K. Care at birth. What are the principles of management of low birth weight baby? Care at birth. Suitable place of delivery, that is in utero transfer to a place with optimum facilities If low birth weight delivery is anticipated, prevention of hypothermia to be wrapped in a blanket or a shawl, so that I already told you, because of the decrease in the brown fat. Efficient resuscitation, appropriate place of care based on the birth weight. Birth weight more than 1800 gram, home care if the baby is otherwise well. 1500 to 1800 gram, secondary level newborn unit. Less than 1500 gram, tertiary level newborn care or a intensive care. So what do we tell? Thermal protection. Because of this baby, I already told, hypothermia and decreased fat. Delay in bathing. Preterm healthy, it is better, or a low birth weight healthy, it is better we delay the bathing for up to 7 days, or until the usually until the umbilical cord falls. Normally in the term baby, on the third day, once the baby is discharged, we advise them bathing. Otherwise, sponge bathing. Maternal contact, kangaroo mother care, warm room, and external heat source. So these are some of the things which can help in thermal protection of the baby. Fluids and feeds. Intravenous fluids for very small babies who are sick. Express milk with gavage or katori spoon, and direct breastfeeding depending on the gestational age and the weight of the baby. What do we monitor, and what are the monitoring and early detection of complications? Weight and other clinical signs, I've already told. Weight of the baby is important because the weight loss is around 10%, 8 to 10%. If the weight loss is more than the expected, one has to worry as to why, whether the child has developed any sepsis or any other infection, or feeding is inadequate, or the child has developed hypothermia. So these things have to be assessed. Electronic monitoring. We do an ultrasound, we do a arterial blood gas. So once the baby, these are the things that have to be monitored. Biochemical monitoring, like serum electrolytes, RFT, C-reactive protein, and appropriate management of specific complications. Suppose the baby has developed sepsis, treat accordingly with the antibiotic. It is a hypoglycemia, symptomatic, treat with dextrose. So identify the complications and treat accordingly. Feeding of a low birth weight babies are relatively difficult because of the following limitation. Many low birth weight are preterm, have inadequate feeding skills, and hence need other methods of feeding, such as spoon or gastric tube feeding. Significant illness in preterm often precludes enteral feeding. Very low birth weights have higher fluid requirement due to excessive insensible water loss. Very low birth weights babies have very low body stores of nutrients at birth, and hence they require supplementation of various nutrients. And also, because of gut immaturity, they are prone to feed intolerance. What are the protocols for feeding a low birth weight baby? Sick babies, this group includes babies with significant respiratory distress syndrome, shock with inotrope support, symptomatic hypoglycemia, electrolyte abnormalities, renal cardiac failure, and neonatal necrotizing enterocolitis. It is important to realize that enteral feeding is important in sick neonates, and even baby with severe distress on ventilator can be started on enteral feeds once acute phase is over. Their color, perfusion, and saturation is normal. Sepsis, unless associated with shock or scleroderma, is not a contraindication for enteral feeding. Healthy low birth weight babies. Enteral feeding should be initiated immediately after birth in healthy babies. An appropriate feeding method is determined by their gestational age as shown in the table. Suppose the baby is less than 28 weeks. It is better we start with IV fluids, as the babies do not have proper sucking effects and no propulsive motility in the gut. Around 28 to 32 weeks, it is better we start with orogastric feeding, as the sucking burst just develops and no coordination between sucking or swallow and breathing. It is feeding by spoon around 32 to 34 weeks and more than 34 weeks, mature suck pattern, more coordination between breathing and swallowing. This is the diagram which says about providing fluids and feeds of a low birth weight, which was discussed earlier. This tells us that if the baby, principles of advanced feeding, if the baby is on IV fluid, we start babies with trophic feeds, and if there is no feed intolerance, then gradually increase to orogastric feeds, and after the baby reaching 30 weeks, try spoon feeding at least twice a day, and also try non-nutritive sucking. If the baby is accepting feeds well, gradually, then increase to spoon feeding and reduce the OG feeds. After the baby reaches more than 32 weeks and child is accepting spoon on or pallida feeds, put the baby on mother's breast before every feed and observe for effective attachment and sucking. If the baby is able to breastfeed effectively, stop pallida feeds and give direct breastfeeding. What are the special situations? In extremely low birth weight babies, they are usually started on parental nutrition from day one of life. Enteral feeds in the form of trophic feeding or minimal enteral nutrition are initiated once the baby is hemodynamically stable. Trophic feeds is given in the dose of 10 to 15 ml per kg per day. IUGR babies with absent or reversal uh, or diastolic flow. Here what happens, they have prolonged hypoxia and are prone for ischemia. Thereby, the redistribution of blood to vital organs are reduced, and there will be increase in the mesenteric vascular resistance and altered mesenteric blood flow, intestinal hypoxia, and thereby these babies are prone to have increased feed intolerance and necrotizing enterocolitis. Nutritional supplements of a low birth weight baby. Newborn babies born before 32 to 34 weeks have inadequate body stores of most nutrients, and preterm babies require supplementation of various nutrients to meet their high demand. Supplementation are required till the baby reaches 40 weeks of gestation. After 40 weeks, their requirements are similar to those babies with birth weight of 1500 to 2499 grams. This is a slide showing the recommended nutritional requirements. This is the slide table showing about the composition of human and other types of milk. Micronutrient deficiency in low birth weight infant fed on EBM with human milk fortifier. The deficit will be around some vitamin A and vitamin D, and some micronutrients in human milk are less, especially with low birth weight infant fed babies. So that is the reason you express best milk and human milk fortifier added, so that this can be compacted as it is required in the low birth weight infant. Methods of supplementing micronutrient supplements: supplementing individual nutrients and fortification of express breast milk. Fortification of with human milk fortifiers increases the nutrient content of the milk without comprising its other beneficial effects. Human milk fortifier 1 gram sachet gives 3.37 kilocalories with 0.27 gram of protein. So thereby babies with HMF should be supplemented with zinc and iron, as this HMF doesn't contain zinc or iron. Supplementing of breast milk with individual nutrients. Once the baby has supplement with calcium, phosphate, vitamin A, B complex, zinc, vitamin D, folate, and iron drops. All this will not be met high. This supplementation of minerals and vitamins would not meet the high protein required in these neonates. So this method is not preferred. So this is a supplementation of a low birth weight infant fed with EBM, express breast milk less than 1500 grams. So HMF, if you give enteral route 1 sachet per 25 ml of EBM, where you start at 100 ml per kg per day. When to stop? When the baby is 2 kg. Then you can start iron dose of 2 mg per kg per day for 2 weeks until 12 months of age. Then multivitamin 0.5 ml enteral route. Feed at when it is around 50 ml per kg per day OD until 12 months of age, and supplement vitamin D. If the baby's low birth weight infant is more than 1500 grams, as per the AIMS protocol, we do supplement iron enteral route 2 mg per kg per day when to start 2 weeks after the delivery, 2 weeks after the birth until 12 months of age, and vitamin D you give 400 international units at the discharge of the baby until 12 months of age. Low birth infant, this is WHO protocol. Babies less than 1500, phosphorus 15 mg per kg, full feed until 40 weeks post 40 weeks. Then calcium 80 mg per kg when the baby is on full feed, and vitamin D 400 international units 2 months after the, and iron 2 mg per kg per day. WHO protocol says in a low birth weight infant baby, EBM feed with express breast milk more than weight of 1500, you give iron. Next, this is the easiest and cheapest method of how we care a low birth weight baby. It's a Kangaroo mother care, a simple method to care the low birth weight baby that includes early and prolonged skin to skin contact with the mother or a substitute caregiver, and exclusive breastfeeding. The natural form of human care stabilizes the body temperature, promotes breastfeeding, prevents infection and other morbidities. And this also leads to early discharge, better neurodevelopment, encourages bonding between mother and infant. And this KMC is initiated in the hospital and continued at home until the baby needs it, and for optimum care or regular follow-up must be ensured. What are the components of KMC? Skin to skin contact and exclusive breastfeeding. How long will you give KMC? Short duration 4 hours. You can give extended 5 to 8 hours, or long 9 to 12 hours, or continuous KMC for more than 12 hours. This duration depends whether we are giving for a sick baby. Initially it might be 4 hours, then you can give it for 5 to 8 hours or 12 hours. Duration to be continued as cumulative completed hours during a 24-hour period. What are the benefits? Most studies say that it's more effective than incubative, providing adequate thermal care, reduces nosocomial infection, improving exclusive breastfeeding and weight gain, foster greater maternal and family involvement in care. What are the senses in an infant that can be got through KMC? One is skin to skin contact, that's touch. The baby listens to her voice, mother's voice and heartbeat, so it's a hearing. Sucks breast milk, it's the taste senses. Eye to eye contact, it's the vision senses. and smells or odor, olfaction. So these are few advantages with this Kangaroo mother care. Timing of initiation of KMC depends on the birth weight. Less than 1200 gram, because of some serious morbidities, this baby should be placed in a specialized center. You treat the problem and then KMC can be initiated. And 1200 to 1800 gram, that they have some serious morbidities to be treated, and then KMC can be initiated. And babies more than 1800 to 2500 gram, usually they are stable and it can be initiated immediately after birth. This is the technique of giving KMC. And the Kangaroo mother care, or any care, any person who, it's not the mother, any person who looking after the baby, either the father or any caregiver can give this Kangaroo mother care. But to follow healthy personal hygiene, hand hygiene before touching the, giving the care. Do not bath till the baby weighs more than till 2500 gram. Sponging may be done. Do not handle baby too frequently. Do not give bottle feed. Do not allow baby to be in contact with sick people. When to discontinue Kangaroo mother care? When the child reaches term gestation or baby weight reaches 2500 gram and the baby starts wriggling to show that it is uncomfortable. Baby pulls out the limbs of the Kangaroo garment and cries and fuses every time mother tries to put the baby back to the skin to skin contact. What are the preterm complications? Early, late. It's already discussed earlier. To sum up, they have respiratory distress syndrome, apnea of prematurity, intraventricular hemorrhage, hypothermia, hypoglycemia, more prone to infections, and hyperbilirubinemia. Late, retinopathy of preterm prematurity, bronchopulmonary dysplasia, osteopenia of prematurity, anemia of prematurity. That is why in the next few slides I'll tell what are all the screening procedures or screening tools to be done in a baby preterm which is discharged from the institution. This is a study showing the neonatal mortality and morbidities in infants born late term as compared to term. They found that the use of surfactant, nasal oxygen, respiratory distress syndrome, hypoglycemia, jaundice or feeding problem decreases as the baby becomes full term. What are the consequences of intrauterine growth restriction? It can be divided into intrapartum, neonatal, long-term consequences, and adulthood. In the intrapartum, they could be acute or chronic hypoxia, meconium aspiration, metabolic acidosis, or could be a fetal death. Neonatal, the baby born, they can have respiratory distress syndrome, seizures, metabolic problems like hypoglycemia, hypocalcemia, hypothermia, feed intolerance, and others. Long-term problems of IUGR are bronchopulmonary dysplasia, cognitive delay, prone for cerebral palsy. Adulthood, diabetes, obesity, hypertension, dyslipidemia, cardiac diseases, stroke, bronchitis, and early menopause. What are the methods to prevent prematurity? Use of antenatal corticosteroids, tocolytic agents like indomethacin, nifedipine have been used, magnesium sulfate for neuroprotection, antibiotics to prevent early onset sepsis. If the mother comes with preterm labor, preterm premature rupture of membranes, so in order to prevent the sepsis to the baby, it is better we start antibiotics and adequate rest. What are the benefits of delayed cord clamping? Decreases mortality in these preterm babies, higher blood pressure and blood volume, less need of blood transfusion, fewer brain hemorrhages, lower risk of NEC, decreases iron deficiency anemia, and improve neurodevelopmental outcome. The delayed cord clamping is up to 1 minute. Antenatal corticosteroids, their benefit is there is reduction 50% in the incidence of respiratory distress syndrome and intraventricular hemorrhage and 40% reduction in mortality. So all mothers at risk of preterm delivery between 24 to 34 weeks, we do give this antenatal steroids. Case of preterm premature rupture of membranes less than 32 weeks of gestation in absence of overt clinical chorioamnionitis, we should not give. And betamethasone and dexamethasone are the antenatal corticosteroids used. Optimal timing is given. Optimal effect occurs after 24 hours of initiating treatment. The effect of one course lasts for 7 days. Now next, what are the things which we do screen this preterm babies or low birth weight or this other newborn babies? Hearing screening. Hearing screening is done to all babies, whether it is term, preterm or a low birth weight, because early hearing handicap to be detected and prevented rather than to have a hearing handicapped child. Screening to be done at least once before the discharge of the baby. For all preterm babies more than 34 weeks to decrease the false positive results. What are the high risk neonates? Baby having jaundice, birth asphyxia, meningitis, where the babies would have received ototoxic drugs in the institution for various sepsis or any meningitis in the hospital, and culture proven sepsis, any intracranial malformation. So screen the newborn babies, whether term, preterm or low birth weight babies. Other screening we do is for the eyes, retinopathy of prematurity. It's a first screening examination should be carried out at 32 weeks of post-menstrual age or 4 weeks of postnatal age, whichever is later. For babies less than 28 weeks, screen at 3 weeks of postnatal age as per the AIMS protocol. Why this is important? ROP screening, because in ROP we have 4 stages. If the baby has gone into stage 3 or 4, the vision may be hampered. So it is better we screen. And if it is in stage 3 or 4, they do some cauterization and central macula will be spared, and the peripheral vision they might have some problem. Instead of leaving the baby without screening for this retinopathy of prematurity, so that we can prevent this blindness. Next is what do we do? Another thing is the cranial ultrasound of the babies, especially this preterm or high risk, whichever is admitted. I already told you these babies are prone for intraventricular hemorrhage or periventricular locomalacia. So to all babies less than 34 weeks of gestational age or birth weight of less than 1.5 kg, first screening is done at 1 to 3 days of life, second screening on the 7th day, third screening on the 14th day, and the last screening is 21st day or just before the discharge. So as you there every year November 17th, and this is the newborn week, November 17th is the World Prematurity Day, where they want to, this year's theme was Together for Babies Born Too Soon and Caring for the Future. So that in the due course, they want to bring down the prematurity as the leading causes of death or morbidity or mortality. Nowadays, we are seeing more preterms is mainly because of the high maternal age and with this assisted infertility technique. And the theme for this newborn week, every year, WHO or Government of India, we have a theme which it's enhancing quality, dignity, and equity of newborn survival. Thank you. Thank you, madam.
And only one participant has posed the question in the chat box. That is, their question is the products that is available in the market, that is baby foods, are sufficient to completely fulfill the nutritional requirement of preterm and low birth weight babies. Hello? Hello? Ma'am, shall I repeat the question?
Hello.
Hello. Madam, one of the participants asked the question with regard to the market available baby foods. That is the nutrient requirements of those Nestle products or of any baby foods. Is it going to fulfill the nutrient content required for preterm or of low birth weight babies?
Madam, I could not hear you. I'm unable to hear you.
Hello.
Hello, madam.
Am I audible, ma'am?
Yeah, you're audible.
Okay. See, one of the delegate, that participant asked the question, that is, the nutrient requirement of preterm babies or of low birth babies can be fulfilled through this market or of baby foods available in the market.
No, madam. Actually, IMS Act is there. So infant milk substitutes have to be banned. But some people are advocating in the private as such, madam, we are not supposed to promote this infant food,
baby foods,
infant milk product. This is baby food.
Yeah, even yesterday, Dr. Arun Gupta mentioned about it. But always the people, like the mothers, or especially the working mothers, want to buy the readily available foods rather than going for preparing the homemade.
Madam,
so any guidelines or suggestions with regard to the homemade foods?
Madam, there is nothing like buying the food. Nowadays, one government of Karnataka, India, they have this maternity leave is extended up to 6 months. So they can, second is exclusive breastfeeding has to be given. The diet to the mother is more important because we have seen many food taboos. They don't supplement either this calcium, iron or whatever has to be given. That is one thing. Second, this express breast milk can be stored and can be given by the caregiver in the house. So there is nothing like they going and buying a formula feed available in the market. It is strengthening the mother, and especially the grandmother. These are the people who are going to give much. With this National Health Mission coming in picture from 2014, we have seen a drastic improvement in the mother-child, when the mother and the baby, regarding the ANC care, the stress, the diet, the stress about the diet. which is easily available. They ask them to eat that. So what we have seen, the institutional deliveries are more, and iron, folic acid, calcium is being given in around 90 to 95% of all ANC mothers are taking. So I feel this giving formula feed is not required. It is the way we care. The what based on the weight and others, I have already told you. The feeding is more important. The patience, how it's not a term baby we feed and leave it. It requires little more patience and attention. And all the time, most of the time we have this daycare center for all the working mothers. So I don't go for any infant milk, what to say, baby food product.
Okay, thank you, ma'am. Like to supplement with your viewpoints, even I would like to state that one of my PhD student did the research study mainly on the growth and development of low birth weight. It's a longitudinal study, she did it. And we could able to notice that after 9 months, till 1.5 years of age, that was a very critical period for the growth of the low birth weight. Like there was a steady like stunted or of thinness could be noticed. Maybe the one of the reason could be the mother's awareness, especially with regard to the nutrition. Like because many mothers like in as per our study, like they were from the low educational background, and also their socioeconomic status was very low, so they couldn't able to like attend or of prepare the homemade, and also they are more burdened with the household work. So with that kind of a constraint, like we could able to see the effect of these lack of nurturing on the growth and development of the low birth weight babies. That's why I feel like more research studies should be carried out on the like feeding practices, especially among the low birth and the preterm babies, and that to be at a community level. Like especially in the initial first 2-3 months, definitely the doctors will going to help them. Like whenever they will approach the doctors, definitely they will help them. But when it comes to after 6 months, even the baby will show the normal growth and development. That time they will neglect it, or they may be busy with other work and they may not have a sufficient time to take care of the baby's nutrient like requirements. That is my personal opinion, madam.
Madam, initially we used to have a joint family. Now it is a nuclear family. That's the reason.
That's true, ma'am. That's true. Yeah. No grannies at home.
That is one thing.
Yes, yes. Okay. So, madam, really, it was a very informative, and like you have covered almost all the issues related with the preterm and low birth weight babies. Like you have covered the issues related to the incidences, what are the causative factors, risk factors, and how the care of preterm babies or of low birth weight babies has to be done, monitoring issues you have touched on, and even you have touched on the early detection, especially the screening issues. You have covered it. Like as per your presentation, we could able to understand that there are many pathways that is leading to low birth weight and also of preterm babies. And even there are many ways through which you can also prevent it. Like you can cut down the incidences level, and each require like the babies with a different birth weight or of different clinical symptoms. There are different kinds of scientific clinical strategies or of scientific method we have to adopt. So together, they encompass a wide array of measurement systems, and also the clinical intervention across many healthcare disciplines are required, and that are yet to be taken hold in Indian context. So I really express my sincere thanks to you, madam, for presenting the very informative talk. On behalf of the University of Mysore and Department of Food Science and Nutrition, and on my personal behalf, I extend my thanks to you, ma'am. Thank you, madam.
Thank you, ma'am.
Thank you, Professor Komala ma'am, for moderating the fourth scientific session. The fifth scientific session focuses on health indicators of neonates and infants by the resource person, Dr. Kuldeep Singh, Professor and Dean of Academics, HOD of Department of Pediatrics, All India Institute of Medical Sciences, Jodhpur. I invite Dr. Ramya Bhaskar, Assistant Professor, Department of Human Development, Avinashi Lingam Institute for Home Science and Higher Education for Women, Coimbatore, to introduce the resource person and moderate fifth scientific session of the webinar. Over to you, Dr. Ramya Bhaskar, ma'am.
Thank you. Good morning to one and all. Three things in life: your health, your mission, and the people you love. That's it. It's a quote by Naval Ravikant, and undeniably, there's nothing more important than the health of our babies. The session now is on the healthcare indicators of neonates and infants, which I'm sure will enlighten us about the scientific indicators to monitor the health of our newborn babies. At the outset, I thank the organizers for giving me an opportunity to introduce the speaker of the session. And indeed, it's a great pleasure to introduce the eminent speaker, Dr. Kuldeep Singh. The profile is very vast, but I have summed up and would like to give a brief introduction. To begin with, his field of interest is public health, adolescent and child health, medical genetics, medical education, and healthcare innovations. After completing MBBS and MD Pediatrics from King George Medical University, Lucknow, and DM in Medical Genetics from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, Sir got involved in developing innovative educational technology for professional development. He has nurtured medical education as a co-convener for MCI designated Regional Training Center for Medical Education Technology. He has been associate editor of annuals of National Academy of Medical Sciences, NJMS, and IJGMR, and also reviewer for many journals. He is also a member of various national, regional, and institutional committees, including Research Advisory Committee, Government of India for Model Rural Health Research Unit at Jaipur, Rajasthan. His skills include clinical care, resource development, and medical research. He is a member of State Rare Disorder Committee. He is the principal investigator for Department of Biotechnology supported National Inherited Disorders Administration Kendra and Health Technology Assessment at AIIMS, Jodhpur. Sir has extensively studied needs in school health education of our society as part of a project on adolescent sexual and reproductive health funded by Grand Challenges Canada. He has been appointed as council member for India-Swedish Innovation Hub in February 2020. Sir has around 75 research publications in various national and international journals, 10 book chapters, and a regular in writing articles for newspapers. He has delivered various invited lectures and presented papers in scientific meetings for which he has won awards as well. The prominent awards are Foundation for Advancement in International Medical Education Research Fellowship Award and Dr. Shamlal Saxena Award for using technology to deliver cost-effective continuing professional development. He has 13 major research projects, 4 completed and 9 ongoing to his credit, funded by agencies like DBT, DHR, and ICMR. He has a remarkable contributions in various community services and creative projects and has held responsible administrative positions. Currently, Sir is working as Dean Academics and Academic Head, School of Public Health at All India Institute for Medical Sciences, Jodhpur. Finally, I would like to mention that the organizers of the webinar have made a right choice by inviting Dr. Kuldeep Singh to speak about health indicators of neonates and infants. And it is a privilege to listen to your talk. Over to you, sir. Thank you.
First of all, thank you, Dr. Sudha, for your kind introduction. Are you able to hear me?
Yes, sir.
Okay. So thanks, Dr. Sudha, for Ramya for the very kind introduction, and Dr. Professor Komla, Head of Human Development at the University of Mysuru, for inviting me for this talk. And also, I would like to thank Dr. Sudha, who has just given a talk, and which is a very comprehensive talk on the neonatal care and the challenges. But there were some queries from some of the audience, that is about the infant feeding foods and how this type of care can be provided in the community. So my talk will be focusing on those aspects, because unless until we are aware about the community problems, we will not be able to provide the best care. As the technology is advancing very fast, so more and more babies are surviving. We have been able to reduce the under 5 mortality rate. We have been also able to reduce the infant mortality rate from the, like 20 years back, it was 70 to now it is 35, but it is still high. And if we know the reason for that is that why we are not able to reduce it further is because of the perinatal mortality rate. And because of the perinatal mortality rate, it is further not reducing. I would also like to apprise you of our Honorable Prime Minister, Shri Narendra Modi ji, who said on 15th August in 2019 that the biggest problem of our country is the population. And the second biggest problem is the education. So unless until the people are prepared for the right reproductive options, our health indicators will not improve. And that's why, in order to convince the policymakers, higher authorities, stakeholders, and other people, and involve everybody in the care of the newborns and the challenges of the newborn, we know to have some idea about what are the indicators. So I will be talking about something about that. And also, this is a very apt forum which has been chosen by the ministry, University of Mysuru, the challenges of the neonatal care and infant protection. I would like to congratulate them for their golden jubilee year of Department of Food Science this year, and they are celebrating through the various webinars, seminars, and the workshop. And this is our institute. AIIMS Jodhpur is located in the center of Rajasthan. Rajasthan is now the biggest, largest state in the country. And the Jodhpur is located in the center of the Rajasthan. This is around 370 kilometers away from Jaipur, the capital of Rajasthan. But from here onward, the various difficult terrains starts. The desert starts from Jodhpur. And also, when we go to the southern side, the hills, Aravalli hills are there. So the Rajasthan has most of the challenges, and AIIMS Jodhpur is tackling most of the challenges in the community level. And among the neonatal care and infant protection, the most important challenges are the perinatal mortality. As per the 2015 estimates, around 3 lakhs women die during pregnancy, childbirth, or in the postnatal period, and 2.6 billion babies are still born, and 2.7 million babies die within the 1 month of birth. This is the most important cause of the high infant mortality rate in our country. Number of people receiving the care is increasing, but the quality of the care is still not evidence-based, because we don't have the sufficient number of parameters or indicators. So there is a need for robust data and indicators of the health beyond the basic data for any impact. So I would like to apprise you that what are the basic data and how we can go about developing further. What is an indicator? With the goal of the good health in the mind, think of an indicator as a measure that helps to quantify the achievement of a goal. If we just concentrate on one thing about it. If we drive our car, then we have multiple indicators. There is a fuel indicator, there is a temperature indicator, and there is a speed indicator. So various indicators are there. So when we say the fuel is low, we are seeing the indicator, although that does not mean that the fuel has already finished. So we can get an idea about how much is the level of the fuel in our car, or what is the speed of our car, when we should slow down, or when we have to increase the speed. So indicator is one important parameter, or it is a measure. Basically, it is a measure that helps to quantify what we are going to achieve. And we till now are discussing most of the basic indicators, and also basic indicators are very important for convincing the policymakers, but still we have to go beyond that. The objective of today's talk will be, what are the definitions and the terminology? What is the importance of health indicators? What is the criteria for a good health indicator? What is the global scenario for the basic indicator? What is the Indian scenario for the basic indicators? And how we can move forward? So health is a state of complete physical, mental, social, and spiritual well-being, and not merely the absence of disease or infirmity. This is a wide definition which is there, although that is not a complete definition of health, because the health is not a state, it is a dynamic. At a moment you does not feel very happy, and mentally you may be not feeling well. So that is also that transient changes in the health can occur. And these changes are much more rapid in the intrauterine period when the baby is developing, and in the first 2 years. As Dr. Sudha has mentioned about that, the 1000 days of the life, that is start inside the uterus. So 280 days are inside the uterus and 720 days are outside the uterus. And these are the most important period of one's life. Actually, this is one of the important things we have to understand. These first 2 years of the life are the most crucial. And unless until we are well prepared financially, physically, mentally to care of the baby, our baby, during these 2 first years, we should not think about the baby. That is the first thing. And that may markedly reduce the challenges of the newborn care. So what is the terminology that when we talk about the various terms, when we say the term live birth is a complete expulsion or the extraction of the baby from the mother, which breathes or shows any sign of evidence of life, such as beating of the heart, pulsation of the umbilical cord, or definite movement of the voluntary muscles. So that is a live birth. So this is a most important term which is being used for the international comparison. On the other hand, stillbirth, we sometimes underestimate because there is not much reporting data about the stillbirth. But this is the most crucial that reflects the health of the society. That is, if we are not giving a good health to the pregnant woman, there are more chances of stillbirth, which go unreported. So stillbirth is a baby who is born with no signs of life at or after 28 weeks of gestation. This is for the international comparison by WHO. In this case, the death is indicated by the fact that after separation of the fetus does not show any sign of life, like beating of the heart, pulsation of the umbilical cord, or definite movement of the voluntary muscles. So this is this as compared to another term which is known as miscarriage. Now miscarriage is differently defined. Like in the West, in the European countries, they say that even at 20 weeks, a baby can be taken, beyond 20 weeks can be taken as a term, as a stillborn. But in our country, from as far as the legal and MTP rules are concerned, up to 28 weeks, we consider as a abortion or miscarriage. What is the perinatal period? It commences at the 22 completed weeks. As per the WHO, if the woman is completed at 22 weeks of gestation, and the baby first 7 days after birth, so this whole period is known as the perinatal period. But for the MTP acts in India, it is 28 weeks. But for the international comparison, it is 22 weeks. So at 22 weeks, because now the neonatal care is improved, as Dr. Sudha has mentioned, that now the basic neonatal service are upgraded to provide care to even a baby who is 500 grams. 500 grams baby is when the mother is having a 22 weeks of gestational age. Whereas at 28 weeks, it is 1 kg. So earlier the definition was 1 kg, but now WHO is reduced to 22 weeks or 500 grams. Even the babies who are less than 500 grams are being surviving intact without any sequelae because of the technology. But that becomes very costly for everybody. For the institute, for the community, for the family, it is too costly to save a baby of a less than 500 grams. Whereas the neonatal period begins with the birth and ends at the 28 completed weeks, completed days after birth. After that, the infant, this whole period from the 28 weeks up to the 1 year of age is known as infantile period. Infant period is up to 1 year of age. So any death which occurs in the first year of life is infant death or infant mortality rate. 1 to 3 is a toddler's age, 3 to 5 is the preschool years. From 5 years, school age starts up to 12 years. And 12 years onward, the adolescence age starts up to 18 years. And 18 years is the adult. So this is a various division of the period of the life. And the first 6 days, 0 to 6 days of the life is known as early neonatal. And the 7 to 7 days is known as late neonatal. So early neonatal deaths can be determined because of the inherent factors in the baby, which can be genetic factors, malformations, care at the time of birth, and the labors and other conditions which can be minimized. Whereas the late neonatal deaths are mostly because of the community, how the care is provided to the baby, the breastfeeding is adequate or not, nutrition and other things are provided or not. So this is our definitions. Perinatal mortality rate is defined as infant under 7 days of age and the fetal deaths more than 28 weeks of gestation per 1000 live birth plus all the fetal deaths. Whereas the infant mortality rate is death prior to the first year of life per 1000 live births. And neonatal mortality is the deaths prior to 28 days of the life per 1000 live birth. And post-neonatal mortality is from death from 28 days to less than 365 days per 1000 live births. So the denominator in all the cases is live births. So live birth is taken as the denominator against which we compare all the mortality indices for the newborn. So coming back to the indicator, indicator is a variable. So its value keeps on changing. And it is also a measure because it is an objective calculation of that value. And the key elements of the health intervention, whether it is a program, service, or a project, are based on these 4 factors, that is the input of process, outputs, outcomes, and the impact. These are the types of broad health indicators in our health system. Inputs and processes constitutes, like example, are availability of the drugs per level of care, basic equipment that is required for the activity type, number of the staff per category per capita, number of the drug shortages, and number of the surgical or obstetrics acts done. Whereas the outputs indicator can be the number of the babies immunized, number of the new cases of the facilities, number of the hospital bed occupation rate, and outcome can be that what is the full immunization rate intervention, what is the incidence and prevalence of the various diseases such as HIV, malaria, or TB, or the number of TB cases detected. Impact is on the outcome, like based on the outcome, it is a life expectancy at the birth, infant mortality, prevalence of the malnourished children under 5. So what we are talking about, the broad indicators are basically the impact of our healthcare systems. And this healthcare system includes the input and process, outputs, and outcomes. So this has been a figure which is given by the WHO for the global reference of the list of the 100 core healthcare indicators. So basically we can divide the indicators domain into 4 categories. One is the health status. That is, what is the sickness level, whether there is any disease, illness or not. What are the risk factors? Risk factors can be that there can be poverty, underprivileged, they can be like under-immunized, There is a susceptibility to infections, malnutrition. These can be the risk factors. Risk factors is that what is the type of behavior one person is having for the HIV or other things. Third type of indicator domain can be the service. What type of service we are offering? The service coverage, whether we are covering whole of the population for the country or not. And lastly, the health systems. Health system is the most important. That is, how many PSCs are there, CSCs they are there, what are the availability of the various facilities, essential newborn care, and the facility for the vaccination, giving the protection against the malnutrition, nutrition rehabilitation centers for caring of the babies who are between 6 months to 5 years of age for the malnutrition. So these health system indicators are also one of the important thing which we have to take into account. So what is the rationale for the health indicators? So indicators are vital in the health interventions because when collected and used regularly, they can provide a reference point for the health intervention. So we can also have the research. When we wish to have some research, we have to have some reference point for the health intervention, for the planning, management, and reporting also. Also, the health indicators allows the managers of the health intervention to assess the trends and identify some of the problems. And also they can act as the early warning signals for the corrective action. So that's why these indicators become more important for the public health specialist. They also become important for the community medicine and family medicine people. They also become important for the government agencies because they have to evolve and they have to provide what is known as the universal health coverage. As the National Health Policy in 2017 dictated that everyone should have the right to the health. And for that, we need to have the research and the reference points, and we have to need to assess the trends and the identify problems. So when we talk about the neonatal care, we just consider the tertiary level care in the biggest hospital of the country. But we never talk about the universal health coverage to the community, to the people in the community, to the last point in the queue. Here comes the role of the rationale for the health indicators. As in 2017, Dr. V.K. Paul, he was the professor of pediatrics and neonatology at AIIMS Delhi, who became the chairperson of the health segment of the Niti Aayog. He declared universal health coverage and launched a program, very important program, that is a Lakshya program. If we go for the Lakshya program, this is a like amalgamation of the community health to the tertiary care. That is, we have to provide the quality health, quality care to the people. The quality becomes now more important than the individual indicator. So what is the characteristic of the good indicator? That it should be a specific. It should be able to indicate what it is focused for. It should be well defined and should be detailed. The second important characteristic of the good indicator is it should be measurable. Measurable means that indicator tells how many or how much can be measured with the identified measurement of the resources. It should be like all the stakeholders should agree that, okay, this is a good indicator and this can be used for the various comparison. It should be relevant. Suppose that whatever indicator in the West may not be relevant for our country. It should be relevant for our country. And it should be time bound. That is, the indicator specifies the time frame of what it is measuring. So we are measuring, suppose during the COVID time, how much we have reduced the infant mortality rate, or what is the level of the pregnant woman care during the COVID time. So that COVID time is that from the March till the September, 6 months, what is the impact. So these things can be used as a characteristic of the good indicator. So are the health indicators are adequate? I will be talking about some of the basic indicators, and I will let you ponder whether we are enough in talking about the health indicators. So WHO has asked in 2015, was asked to propose it and trace the indicators for quality of maternal and newborn health care provided at the healthcare facility level that could be used for the global comparisons. After consultation with a wide range of international stakeholders and experts in the quality of care, a core set of 15 indicators was proposed. Now, these 15 indicators also included the maternal health, newborn health, and some general indicator. So these indicators were thought to be good markers of the life-saving interventions and were obtained via consensus. But they have not been formally assessed to determine whether they complement or link to the data already routinely collected for the maternal and newborn health. There are many surveys, there are census also, which collect the basic data. Sometimes they may not be complete in themselves. And that's why there is a need for a more health indicators. And among health indicators for the newborn, they have 5 health indicators which they propose to be used. And one is the proportion of the health facilities with the functional bags and masks in the delivery areas of the maternity services. That means even the smallest PSC or CSC should have the functional bags and masks for resuscitating the baby. And 2 is the proportion of the newborns who received all the 4 elements of the essential newborn care. And these essential newborn care is very important. Everybody should know about this. Immediate and thorough drying, as Madam was already alluded on. Immediate skin-to-skin contact, that is known as kangaroo mother care. Delayed cord clamping, because it will increase in the hemoglobin of the baby. And the initiation of the breastfeeding. Yesterday also it was a lot of discussion on the breastfeeding. And the breastfeeding is the one of the natural indicator of the care to the baby. So there is nothing like a breastfeeding. But again, we have to go to the mother level. And mother's training should not only start during the pregnancy, but before that. In the adolescent age, from 12 years to 18 years, all the person, even the boys and the girls, should be told about the benefits of the breastfeeding. Unless until we know about the scientific basis of these indicators, these 4 elements, we will not be able to provide care when our baby is born. And 3 is the proportion of the health facilities in which the kangaroo mother care is operational. Madam has talked about the kangaroo mother care, but there is failure because we never understand what is kangaroo mother care. So kangaroo mother care should be offered to every baby, irrespective of the weight of the baby. But in the NICUs, we have to have some babies who can be offered, and some babies who are sick cannot be offered. And 4 is the facility with the neonatal mortality rate disaggregated by the birth weight. So do we have the data of more than 4 kg babies, between 2.5 to 4 kg, between 2 to 2.5 kg, and 1.5 to 9 kg, and less than that. So this neonatal mortality data should also be disaggregated. The proportion of the health facilities offering maternity services certified by the Baby Friendly Hospital Initiative. That means the breastfeeding promotion is done or not. That is also very important, and whether they are certified every 2 years. So now coming to the commonly used health indicators which we use in our society is globally, the global number of newborns death was 5 million in 1990 and has reduced to 2.4 million in 2019. But the children still face the greatest risk of death in their first 28 days. So this becomes a very important area. In 2019, 47% of all under 5 deaths occurred in the newborn period. And out of these, 1/3 of the babies dying on the day of birth. This is very important indicator. That means the day of birth becomes the most crucial indicator. And 3/4 of the babies are dying within the first week. Among the neonatal deaths, there was a lack of quality care at the birth, or the skilled care, which was the most important indicator for the death of the baby. And this quality of the care was the type of obstetric monitoring provided to the mother, the care at the time of immediately after the delivery of the baby, cord clamping, aseptic precautions to be taken, and the baby care, kangaroo mother care to be provided immediately after birth, and the lack of the treatment immediately after birth in the first 7 days of the life. And when they characterized the type of the newborn deaths, they found that most of the deaths were in the preterm babies. And uh, the second most important was the intrapartum related complications. That is that during the time of delivery, there was a less monitoring of baby, and the baby has the intracardiac asphyxia, intrauterine asphyxia, which leads to the baby born with a disability. And the third was the infections. Infection is still the most important cause of our country because of the poor personal hygiene. And when they further analyzed this data, then they found that pregnant women who receive the good antenatal care, I would go beyond that also. It is not the antenatal care. It should be like every girl and every boy should be told about the antenatal care, how the care should be taken. So they found that those who have received good antenatal care, there was 16% less likely to lose their babies. And they were 24% less likely to experience preterm birth. Now, these are also important factors for the population control, because if we care for our baby, there's a less chances of having a low birth weight baby. There's less chances of baby having a disability because of birth asphyxia. And that's why we'll not go for the another baby, and we will space for the another baby. So again, these are some of the important things which are being highlighted with these indicators. Globally, as you can see that India stands second among the neonatal mortality rate by country in 2000. And now presently the situation is very high. That is still our country is the first. Talk about the parental mortality rate, the India is again on the second rank. Now these are the global trend. That is, if we have every year 2.6 million babies die in the first 28 days of life, and the top causes are prematurity, complications during the birth because of intrauterine asphyxia, and the third is the infections. They are all three preventable causes. And additional 2.6% of the baby die because of the stillbirth. So again, that is not being documented very highly in our country. In the West, they document each and every stillbirth, but sometimes here the intrauterine death occurs at home and the baby is disposed and not reported. But 75% of the newborn death can be prevented by the high quality care. It is not necessary to have the high sophisticated care, but only the simple high quality care by the antenatal monitoring, right antenatal care, good quality antenatal care, and delivery at the facility where the trained birth attendant is available. Even at home, it is not necessary that it should be institutional delivery. Now, I'll talk about the stillbirth because this is still a neglected tragedy. And every day 7,000 women experience a stillbirth. And the key causes are pregnancy and childhood complications, lifestyle factors, diabetes and hypertension, maternal infections like syphilis, malaria and HIV, preterm birth and birth defects. So some of these cannot be prevented. Like birth defect, we don't have any, once they occur inside the uterus, we don't have any control. But the other things like diabetes and hypertension can be detected by the simple measures, and they can be prevented. Good hygiene, personal care can be provided to the mother. So most stillbirth can be prevented before, during and after pregnancy by family planning, good health and nutrition, quality antenatal care, and quality care during the childbirth. That is also very important. So where our country stands, the countries with the highest neonatal mortality are India, 7,79,000 neonatal deaths. Nigeria is second, Pakistan is third, and you can see that Bangladesh is coming lower down and Nepal is still lower down. The global trends again says that India has the highest top country with the highest number of newborn death. So we are able to now prevent the infant death, but we are unable to prevent the neonatal death. Among these, the neonatal death, it is the premature and low birth weight. In the Southeast Asian region also, you can say that India is topping the list in the neonatal mortality. And also it is topping the list second among various countries, except for Timor-Leste. India is second in the 44 infant mortality rate overall of the country. If we compare the Southeast Asian region, the causes of neonatal death, so you can again see that the most important cause is prematurity and low birth weight. Second is the birth trauma during time of delivery. And the third is 16.5 is the sepsis and other infectious condition. They can be simply simply prevented. Now coming to the India. So India, we have now moved toward the sustainable development goals, but still if we compare the 2012 figure, 2013 report says that our infant mortality rate is still high, and our neonatal mortality rate is also high. It is more than, and the distribution of these deaths in the number of days is based on the 2160 neonatal deaths record. That is the first important cause, is the first day of the life, the most important cause for reason for the death. Now, these are the comparison of the early neonatal versus the stillborn. So stillborn is again constant. That depends on the antenatal care. And this is the cause of the infant deaths, prematurity, birth sepsis. And if we talk about the infant deaths, the acute respiratory, lower respiratory tract infection is important cause. Now, when we control all these conditions, then you will see that the figure moves toward the congenital anomalies. So if we control the lower respiratory tract infections, prematurity, and the birth asphyxia, then the congenital anomalies are going to occupy a larger portion, and some of the other causes, which are non-communicable disease, can be the important factor for the neonatal death. National Family Health Survey 4 that India has still a high mortality ratio among the infant and the newborn, and the neonatal mortality rate, maternal mortality rate is 167, whereas the neonatal mortality is 25, and out of these the under 5 mortality is 43. So trends in the early childhood mortality rates are that under 5 mortality is high because of pneumonia, but the neonatal mortality is not reducing further as compared to the NFHS 1 to 4. It is almost same. Now this is the figures from the central and the North India, in which the neonatal mortality is 29.5 for the India, whereas for the North India, Chandigarh has the highest neonatal mortality, and the post-neonatal mortality is 8.1. The Delhi has the highest, and infant mortality rate, that Uttarakhand is the highest, whereas the child mortality is highest in the Delhi area, and under 5 mortality overall is highest in Rajasthan. And that is true because of the care given to the girl child, it is high. Now in the East and Northeast India, if we can compare the figures, so in the Bihar still has the highest under 5 mortality. And in the Northeast region area, the highest figure is going for the Assam and Mizoram. When we talk about the West and South India, the figure are very encouraging. They have a less of these mortality. As we can see that in the Karnataka, it is under 5 mortality is 31.5. Infant mortality is 26.9. Very importantly, if you can see this figure, when you see the Kerala, the neonatal mortality is just 4.4. Post-neonatal mortality is 1.2. Infant mortality is 5.6. And under 5 mortality is 7.1. It is a very stark contrast to the rest of the country that the Kerala has reached the infant mortality rate of a single digit, 5, 9. Infant mortality is less than 9. Now these figures are as good as the Western countries. And the reason is, one most important reason is the full utilization of the health services which are available to the community. So they make utilize every facility, whether it is a PSC or CSC or at home. They make best use of all the resources which are available there. And appropriate time they are referred also. Their services are available to take care of the babies when they are sick to the higher center. So I think things which indicate that our infant mortality and the neonatal mortality is still high, but these are the basic indicator which may not reflect the quality of the care to the society. So what is the way forward? We have to think about not only our present, but also the future. And also we have to go into the back. We have to review the back. What is the situation there in 2009, 1990, 2010? What is going to happen in 2030? And what type of care we expect in 2050? So this is a chart which has been, it is a projected chart which are based on the data from 2010 with the 2011 consensus, and they the average rate has been taken, and they found that the still for the Southeast Asian region it will be 2070 to reach the figure below 10, whereas the sub-Saharan African region will take 100 more years to reach those targets. So this will take 110 years for the African newborns, which is nearly 3 times longer than this change took in the rich country, despite the new interventions. So again, coming back, the way forward is that we have to concentrate on the 3 most important indicators of the health, which can give rise to newborn death. And this is of preterm birth. So health facility should be apprised about the Lakshya program, about the antenatal corticosteroids, preterm labor management, Kangaroo mother care, and all the deliveries should take place in a place where the trained person is available, not necessarily at a tertiary care center, but even in the primary or in the home settings. So the skilled attendance and the remote monitoring with the obstetricians will highly help in this preventing the complications of intrauterine complications like hemorrhage, premature separation of the baby and the hemorrhage, APH, and also birth asphyxia. And also baby should be provided immediate resuscitation. So bag and mask should be available at the facility where the delivery take place. And the third is the neonatal infections, that is prevention with the help of essential newborn care, especially the breastfeeding. Because somebody was asking about the like Nestle. Now these food products are not recommended by any doctor, because as a medical profession we know that the human milk is made only for the human, whereas the cattle's milk is made only for the cattle's. Cow's milk is only made for the cow's baby offspring. It is not made for the human milks. It will cause problems if we start giving the cow's milk or the goat milk or the camel's milk to the babies, because they have a different constitution. Even if the baby is preterm, there is a letdown reflex. If the mother is given a conducive environment, the letdown reflex let her give the milk. Even if it is smaller in amount, that is a more calories, more antibodies, and more productive values, and should be administered to the baby. So these are the things which are very important. And now when we are talking about the COVID time, everybody knows about the hand hygiene. So I think why not to take this message to everybody, to everywhere, universally, that the hand hygiene practice should be followed at every step, whether it is a newborn care, touching the baby, handling the baby, or giving a vaccination or giving some food products, hand hygiene should be maintained. So I think this, with this help, this in the health indicators may be improved, and we can compare in the coming years. That is what is the trend and what next level of the quality should. So the 71% of the newborn deaths can be prevented by actionable now without the intensive care. And Dr. Sudha has talked about the care during the intensive care in a tertiary care hospital with all the facilities. But even these 3 interventions with the help of health indicators can help achieve our goal for the society. This is my end of this talk. I would like to acknowledge my senior resident who is BM student in neonatology, Dr. Rohit Sachidharan, who has helped in preparing, help me attain some of the data. And also acknowledge the WHO, UNICEF, and Lancets, from which I had taken some of the data for the purpose of this presentation. And I would like to also acknowledge Professor Komla for giving an opportunity for this part in the northern India, for the western desert area, to talk about some of the my thoughts about the health indicators and how we can improve the health of the country by going in a holistic way. Thank
Thank you, sir. Thank you, sir, for a very informative talk on health indicators of neonates and infants. So, as of now, there are some questions that has been asked. Sir, can I ask you the questions now?
Yeah, sure.
There is one question from the delegate. It is traditional treatment is better than the medicinal treatment? If no, isn't medicinal drugs have any ill effect on baby? And it can cause major health issues concerning the newborn baby. And the question is, what will be the first priority as far as treatment is concerned in rural areas where there is no availability of hospitals?
This is a very good and apt question. And I think this is more important. If I say, because of my experience, if I say that the medicines are not required always, we just considered modern medicine as a allopathic. It is not correct. Modern medicine is a evidence based, and we never recommend drugs without having evidence. We never, allopathy is a word which is given by the homeopaths. Those who practice homeopath, they say that other medicine is allopathy. So they say that the allopathy is it is a medicine based. And in our India also, the culture has such that unless until you give away some medication, some tablets or some syrups, the patient will not be satisfied. But the correct answer is it is not required. If I go by Pareto's law says that the 80% of the health problems can be solved by 20% of the simple solutions. And that these 20% of simple solutions are oral rehydration therapy, sepsis, personal hygiene, breastfeeding, and adequate growth monitoring, and a good antenatal care. So simple, there is no need for medication. So when we talk about, I indicated in the last slide that there are only 3 factors which can provide the best care to the society. That is, if we can prevent the prematurity by providing the care, if we provide the care during the labor, and if we provide the asepsis during the delivery, we can avoid medications, and even we can avoid the care which is required in a tertiary care center. So even a rural area can provide these care. Only thing is the education is required. Now, I would like to add one thing, that is education is a word. Earlier, we used to talk about the literacy. That is, if the person has ability to read and write and sign, he is considered to be literate. Then come the education. The education was that he should be able to make judgment, and he should be able to read and give the comments on those reading ability. Now, when we say about education is not enough for the behavior change. We earlier thought that the education would bring about the behavior change. It is not. The education does not bring about the behavior change unless until we use the nudge theory. It is a behavioral insight theory. Nudge theory is that we give the choice. Suppose when we say that wear the face mask, nobody will wear. But if we say that you will be only allowed if you wear the face mask, then the people start wearing. So this is a behavior change. Humne bola when we say tokna, in Hindi word is tokna. Similarly, the word is nudging. So we have to nudge our society for good behaviors. And these good behavior are personal hygiene is the most important. To the pregnant woman is another important. So when we see all these things, we can provide the care to the village, rural area also, and we can avoid the medications also. Medication does have the side effects. And the traditional, when we talk about the traditional medicine, they have a higher value. Actually, at AIIMS Jodhpur, we have Sirohi is a tribal area, 200 kilometers from here. And Ministry of Tribal Affairs has given a center of excellence to AIIMS Jodhpur. And we are studying their traditional practices. And we found something very good about those traditional practice. These traditional herbs and medicines are very useful. They have a lesser of the side effects for some common problems, but they are not useful when when we have accidents, when there's emergencies, or when there's poisonings. So in those situations, we have to take the help of the modern medicine. So whenever there is a surgical requirement is there, when there is a emergency treatment is required, accidents are there, we have to opt for the modern medicine. But a common cold and common fevers, traditional medicine are quite useful.
Okay, sir. Thank you so much. That was the only question, and it is a great presentation and a very great learning for all of us. So, as you said, certainly learning may begin in the classroom, but it doesn't end there. So, that means knowing about the health indicators to identify some of the problems in the newborns, I think it is needed for everyone. So I would like to just summarize about the talk. Just like Sir spoke about the challenges on the perinatal mortality and the importance of the care that has to be given during the period. And very clearly, Sir explained about the indicators as measures to assess health and how to reach the goal of achieving good health using these indicators and the types of health indicators. And Sir also explained about the division of indicators according to the domains such as health status, risk factors, service coverage, and health systems. And why these health indicators are vital? Why do we need it? Because it's the importance of the community health as well as the universal health coverage. So, Sir also explained very clearly about the characteristics of a good health indicator, and the indicators of maternal and infants' health can lead to plan a life-saving intervention. It can be like quality care, personal hygiene, and infections, etc. So health status of infants in India was very clearly given by Sir. The neonatal death rate, the infant mortality rate in India, and what indicators are there to check them. So the health indicators show us how we were 10 years back and our present condition and what can be expected in future. So basically the indicators of health will lead towards strategizing interventions to prevent mortality and death rate in the newborns and promote health in life. So, sir, the session was really very informative, and with that, on this occasion of Golden Jubilee celebration of the Department of Food Science and Nutrition, and in commemoration of Infant Protection Day and Newborn Care Week, with great pleasure, I thank you, sir, and I thank the organizers and the convener of the webinar, Professor Komala ma'am, for giving me an opportunity. And I thank you all once again. Thank you.
Thank you, Dr. Ramya.
Thank you.
introduce.
Hello.
We can minimize this.
Which one you want to?
Wait, something came in.
They are presenting, they are going to give introduction about you.
But I should hear.
Huh?
I should hear that.
Good afternoon, everyone. After an explicit presentation by Dr. Kuldeep Singh on health indicators of neonates and infants, we move on to the last session of the webinar. Monitoring infants' growth and identifying the concerns early are important. It is a strategy to detect early the growth delay, to create awareness among caregivers, enhance the delivery of primary health care, and identify infants at risk. In addition, it also aids in assessing if infants' milestones are developing age appropriately, which is intricately influenced by a combination of genetic and psychosocial factors. Effective screening and surveillance is equally important and is in the need of the hour to promote optimum growth and development of infants. Let's understand about its significance from a very renowned speaker, Dr. Srinivasan Venkatesan. It's an honor to introduce Dr. Venkatesan. Sir is the Dean, Research, Professor and Head, Department of Clinical Psychology at All India Institute of Speech and Hearing, Mysore, Karnataka, and alumnus of National Institute of Mental Health and Neurosciences, Bangalore. Sir, doctoral thesis was on development and validation of neuropsychological test battery for adults with intellectual disabilities. Sir has also served as a faculty at the National Institute for Empowerment of Persons with Intellectual Disabilities, Secunderabad, till 1998. He has authored over 30 books, published 160 research articles, and conducted over 330 workshops for various audiences on topics related to children with special needs. He also teaches postgraduate students and guides scholars in their doctoral research work. Sir is the recipient of several awards and accolades, including the gold medal from the former President of India in the year 1994. His publications have received Google Scholar H-index of 16, ITIL index of 29 with 22,000 views on academia.education, ResearchGate score of 22.51 and 92,091 reads, which is higher than 75% of the group members as on date. With this brief introduction, I extend a very warm welcome to you, sir. Over to you.
Thank you. Thank you very much for that flattering introduction. Am I audible?
Yes, sir.
I'll start my screen sharing. Good. Back. The topic that I have to address today is infant growth, monitoring, screening, and surveillance. Let me confess in the beginning, my presentation will be more bent towards clinical psychology and practice with children and infants that I do every day in my clinics. Let me start with a very impressive quote by Maria Montessori. She says, development is a series of rebirths. So which means an infant is undergoing many rebirths over and again. What shall we be covering today? I'll cover some basic terms to begin with, some of which you might know. Then I will go into infant and child development basics, which is very important to understand the psychological background. There are laws and principles by which development occurs in infants and children. I'll cover a brief of that, which you might know. Then we'll come to indications for developmental assessment. What sort of children, in which kind of cases, where is developmental assessment indicated, where not, we'll cover that. Then I'll give you some more further clarification on the basic terms like monitoring, screening, surveillance, and follow-up before we go into the aims, importance, and areas covered under developmental assessment and their implications for the impairments and disabilities. At a very young age, you can screen out infants or children for visual impairment, hearing impairment, cerebral palsy, physical handicaps, or intellectual disabilities. So that's a very important thing because we have been talking of early intervention services, early identification. There are some reasons for developmental assessment we should know, otherwise the assessment can go wrong. What are the areas we cover? What are the tools available in India? Most of us are unaware and we rely on foreign tools only for developmental assessment. I'll take off a little time to tell you there are many available standardized tools for developmental assessment available in India and which we are using in our institute. And there are accepted standards for developmental assessment, and there are red flags from developmental assessment which tell us there is a danger around the corner. Then what promotional activities, and a word of caution I want to add about the parenting related to developmental assessment. To begin with, though you may be very development is defined as a progressive series of orderly predictable changes. Now, every development in children happens in qualitative as well as quantitative. So qualitative changes and quantitative changes together, it is called as development, whereas only quantitative changes we refer to as growth. So a slight clarification is there. Growth is only to do with changes in weight, height, length, head circumference and all that, whereas development is a broader term which covers. And in both growth and development, maturation as well as the environment plays a very important role. Psychologists have a long drawn attention to the fact that children should be allowed to mature before we expect them to do certain behavior. For example, if it is toilet training, you can't train a 1-year-old child to train toilet. If it is reading or writing, you can't force a 1.5-year child to do a writing of alphabet. But unfortunately, these things are happening nowadays, and I'll come to that later. There is a maturation requirement for every developmental activity, and a correct optimum time is also there when you should stimulate them, when not to stimulate them, where not to stimulate, how to not overstimulate them or understimulate. We have a series of environment enrichment studies where animals who have been grown in enriched environment have grown well. Their cognitive developments have come well. Those who have been in dull, boring, unenriched environments have shown lower brain weight, lower intelligence, lower cognitive development. We face in our daily practice a lot of children who have development delays. What is a development delay? We go by the physical age, if you know that correctly. What is the developmental age of a given child? We give 25% departure. For example, 10-year-old child has less than 75%, that is only 7.5 years and below, then we call it as a development delay. Now, since we are talking of younger children, if it is a 5-year-old child, a 4-year is not so much of a concern. whereas a 2-year developmental age is a great concern. 1-year developmental age is still more a greater concern. So you keep the 25% as a arbitrary kind of a percentage we have kept to call them a development. We have not only development delay, there is also a lot of children we get who have deviance. Examples of children with cerebral palsy. Deviance is they have milestones which are outside the typical sequence. How we know it doesn't go in that way, it goes in a different pattern. Then we call it a deviance. There is also a developmental dissociation where what happens, you find these children will have different rates of development for different domains. For example, in the case of autism, you would find the language development is in total variance and social development is in different variance, whereas self-help development is in another tangent. So you would not find the congruence between the different areas of, so you would find it's very confusing whether the child is growing properly or not growing at all. So this is one example of developmental dissociation. Developmental regression, we do also have cases of kids coming who develop properly, suddenly there is something happening and then they regress. For example, muscular dystrophy, I've written one example, or post-encephalitic sequelae, where children have developed in 5 years. Suddenly she drops and comes to 2 years or even less than that. I've had example of a 5-year-old girl who was supposed to go to a school on Monday. On Friday, she gets encephalitis attack, and by Monday when she comes here, her developmental age is hardly 9 months. So which means the child has regressed rapidly. Let us also be clear about certain elements about child psychology. This is some common things we should know, and putting it in perspective. Child is not a miniature. Unfortunately, many known or unknown people or laymen as well as professionals, we start reading adult feelings in children. I get a mother recently who says, my child has become a liar and he started telling a lot of lies. What do I do before he becomes a thug or an antisocial element? I think he's having an antisocial personality problem. I saw in the Google. It's wrong. You see, it's not, the child is not telling lie. It is a fantasy world where it is creating fantasy. There are similarly many things which happen in children which adults should not read from their perspective. Fear of darkness, fear of strangers is perfectly all right for a particular age. But if it happens at a little later age, then we consider it subnormal. So very important that you should know what happens at what age, which child is, and we should realize different children are, every child is different. No two children are same. Even siblings, if you take a 3-year-old, another 3-year-old, you cannot say he's an exact photocopy of the other child. Every child will, there are inter-individual differences, intra-individual. So every child has its own rate and we should give a lot of allowance to accommodate those differences. Otherwise, parents get panicky, doctors also get panicky, they'll spread that anxiety to the parents. And nowadays, I find every small 1.5-year child is also being diagnosed as autism and attention disorder. All that is happening around everywhere. But another false notion is children are not susceptible to problems. What is there for children to feel? What is the strain? They are not like adults, they don't have big responsibility. No, it's not. Even a small child, a 1-year-old child, a 6-month-old child, a newborn child can be susceptible to. We have one condition called as anaclitic depression. We recognize in clinical psychology, where a newborn, a less than 3-month child also can suffer from depression. And in depression, they will not have the adult depression features, like suicidal idea or crying. Their situation will be different and you require an expert to identify its anaclitic depression. Same way, we have to also face a lot of social issues when it comes to development in children, that it's after all our fate. We can't do anything about it. They are born like that. No, not at all. The early you identify children, you can do a lot of things about them. Well, there is also another component of a lot of errors that happen around in developmental assessment. It is unavoidable to some extent, inevitable to some extent. Say that it's a necessary work that every child should undergo. Training is also required. Not everybody can claim expertise in developmental assessment. You have to be trained. For example, administering a Bailey scale or any other tool, which I'll be saying later, you are to be trained. Unless you are trained, the assessment can go wrong. So assessment be conducted in the context of the culture. You can't use a foreign tool on an Indian child, but this is what happens many of the time. You use a CARS or autism rating scale of some other country and try to say some problem is there. You use a Denver's developmental screening test and say our children are having a problem. Please don't do that. There is also a cultural component we have to keep in mind when you select tests. These are quick points. I'll just run through them. Development involves change. Early development is more critical. They are a product of maturation as well as learning. The pattern has a specific characteristic. Every development is predictable. It doesn't happen haphazardly. There are inter-individual differences, I have already said. They go by stage. Developmental tasks are given in every period, and each child has to go through that and then get into the next stage, and the happiness varies for each stage. Development proceeds from general to specific. First, generic development happens. Then the specific. For example, a child will know or learn a generic component like animal or bow, and then he will come to know a bow is for a specific dog. Otherwise, earlier he would say a cat is also bow, a dog is also a bow, a buffalo is also a bow. Then he comes to know a particular animal is called bow, and then further later he comes to know that this is a dog. And then further later he comes to know this is a particular breed of the dog. So what is happening there? They happen to develop from general to specific, but it happens continuously, and you should also understand it proceeds at different rates. There are different perspectives. Some people say there are universal norms. All across the globe, there's only one common norm for all the infants, all the children. Some argue it is not so. It will vary from local places because there are environmental variation, cultural differences, situational differences. So in some places, some kind of developments are faster. In some other places, or some other time also. It depends on. Nowadays in Corona, you find children are restricted in physical movement. Very likely, the physical development of children will be slowed down now compared to an earlier time when they were running around all the places. So these are some issues. Now, in the developmental assessment, the goal is not to generate a diagnosis. We are not here to label children. You don't label children. You have to find out what they can do, what they cannot do, how much they can do. We call it as a developmental mapping. That's what we do for every child. And this is done for especially children who are high-risk babies, especially the low birth weight, small for dates, or intrauterine growth retarded. These are all some conditions I have listed where developmental assessment must happen mandatorily. Children who have suffered prematurity, birth asphyxia or such insult, or those who have chromosomal aberrations suspected where a screening is required, or those who have genetic or family history. In such case, developmental assessment is very much required. Conditions like sickle cell anemia or tuberous sclerosis. There are also indications for developmental assessment when you find a phenotypical abnormality. For example, you see a cleft palate or low set ears or an extra finger in the palm. Such children require a developmental assessment. Better to get it done. Then there are also instances of when victims of environmental insults. There is huge domestic violence happening in the baby's house. There is what we know as baby battering syndrome, where small children are beaten up by a drunkard father. Such children have a high risk for developmental tragedies. Where there is unsafe hygiene or teenage pregnancy, high levels of neighborhood crime. These are all conditions where such children must undergo developmental assessment periodically. Not only that, they must have a developmental record. It should be monitored regularly. Monitoring is to do with day-to-day noting. This is some habit we do not have in our country at all. Parents have very little idea about monitoring what they did. In fact, when I ask for the developmental history, half of the parents are not even remembering when the baby started sitting when they started walking, when they started, they just infer from some memory, which may not be right also. So what happens, the growth should be plotted properly. Every child must have a growth chart. There should be a book. There should be a maintenance of record. That should be done regularly and by the mother or the concerned health worker. But every child must mandatorily have a, then we can know where the faults are happening, where the curve is going up or down. But I doubt how much of our parents are aware of this, how much of our system is geared into it. For every child, it's a needed thing. Then screening, this is one way of monitoring. Screening is also very important, where at a particular point of time, you would screen what are those risk categories, where it should be. And you should, screening will help us to, we get a lot of children who have speech delay. For example, he is 2.5, 3 years old, but he is not speaking a single word also. And the other children at his age are speaking in long sentences. So what happens, there should be a speech screener. We have certain tools for that, which will help us to screen the speech delay. That speech delay, if it is identified early and intervened through speech therapy, the child can improve and it can save a lot of calamities later. Many of such children who have extreme speech delays in infancy, childhood and all, we have found 70 to 80% of them later turn into be a learning disabled. So learning disability is an outcome of a early speech delay. So if you can handle speech delay early, the learning disability can be even avoided. We have certain psychological tests also where you can find the prodromal symptoms of mental illness, where by the responses what the people give, the respondents give, we can say if not now, in 6 months or in 1 year or in a couple of years, there's going to be a mental breakdown. Their child or the adolescent is going to have a problem. So we have possibility of doing such kind of things. Surveillance is a big broader term where you have to do across a lot of places, and it will be in data you have to have for a vast population. It helps in prevention. You have to survey and keep the record, and it's a macro level activity. And follow-up is very, very important in developmental assessment. Just one time off record is not enough. You have to keep on following up how it was then, how it is now. It's a continuous process. There are methods of doing developmental assessment through screening, monitoring, surveillance, observation, case history, development history, baby diaries or baby records. We use development schedules or behavior rating scales or high-risk register. High-risk register is very important to find out children who may turn out to be hard of hearing or deaf or even blind. So these are very, very important. Now, when all these records are maintained, many parents I find become unduly anxious. They become, something is happening to my child, not necessarily. Record keeping is a very needed thing. That's the point I want to highlight in all this. Now, we have aims of this infant growth monitoring to identify children who are having deviation, who are large for their age, who are wasted or have low body mass index, or who are having failure to thrive kid. These are some conditions I feel where the developmental assessment has to happen very, very importantly. It helps us to promote good programs also. Now, coming to developmental milestone, observation I have to make in the Indian scenario is 90% of the parents, at least in our country, in the rural or urban area, have no baby record. So it is all left to one's memory. So when we ask a child, a parent, when did he walk? When did he talk? When did he start the first word? So they may say from memory something like that. But we have done a study to even find how far it is closer to reality. Unfortunately, it is not. What they perceive, what they report, and what happens is a huge disparity between milestones as they perceive it happened and what it has actually happened. So the perception, many parents do not even know the age of the child. Because now with the little advancement with Aadhaar card and all, date of birth records are there. But a few years before, I remember when I used to ask the mothers or father, how old is your child? They say, we are not educated like you, sir. You are educated. You should tell what is the age of the child. How would we know? So something they will return the question to us. So it is all left to memory. So where do we go for authentic record, reliable record, and what we call as retrospective falsification? You forget what has happened, even what age, when did they do this activity, all this is not. Fathers are even more poor informants we find in Indian culture than mothers. Mothers to some extent may remember when the child walked or talked with father, and they kind of guesswork, estimates are given. Here, it's all the more important in our dealings with children who are having sensory problems, vestibular problems, vision problems, who have hard of hearing. It's very important to know what age the child started having speech problem, etc. Same way, it covers areas like motor, personal, social, play activities, language, receptive language, expressive language, academic. All these areas have to be part of your. Here I'm giving a little more examples of developmental surveillance. When it comes to visual impairment to screen, we have to have certain key questions. Does the child follow a moving object before his eyes? Yes or no? Does the child reach out toys or things held in front of him? Yes or no? Does the one eye move differently from that of the other? Are the eyes red, have yellow discharge or flow of tears continuously? Does the child tend to bring pictures too close to his eye? Now, these are some indications very early, from 3 to 6 years itself. You can find out that there is a risk for visual impairment. Same way for hearing impairment, questions like these are important in your questionnaire. Does the child turn to the source of sound or voice when called from behind? Does the child localize, track, or recognize sound, voice? Is there any discharge from the ear? If there is a ear discharge, the chances of central auditory problems are there. Does he or she use excessive gestures while communicating? Then there is a risk for hearing problem. Does he or she not speak at all, have no speech properly, or they use defective speech with fewer pronunciation, etc.? They are under risk. Does he or she fail to understand spoken language? These are all some questions if you ask for small children. If you get the accurate answers, you can screen them and refer them to institutions like ours. We have also some questions related to physical conditions. Does the child show delay in milestone? Does the child have unsteady head even by 8 months of age? Is the muscle tone of the body different, like stiffness somewhere and flaccid somewhere? Does the child show preference for one side of the body than the other? Or does he exhibit some unusual posture? Then you can suspect the CP, cerebral palsy. For intellectually disabled or the children, we can have questions like, does he respond to name or voice? Does he hold his head steady? Does he walk as per his age? Is there a toilet control, etc.? These questions will give us some idea on whether the development is according to the age. Same way we have questions for physical and emotional disability. Now, quickly coming to the conditions where developmental assessment is required is it has to be carried out in a slow, unhurried, relaxed area. It cannot be done in a hurried way. It requires a lot of time to sit with each child, the parent, and observe the child and do that. It should not be done in a hurried way. Play-based activities is what we do. When we do a developmental assessment, we spend a lot of time by doing play activities and observe the child because you can't do an IQ testing like we do for adults by giving equipments and asking the questions and answering. It's for children, it is totally different. It should be play-based. And the child should not be tired or hungry at that time. If he is ill or irritable at the time, unlikely you will get the correct responses. We use something called as a developmental assessment kit. In our institute, we have developed what is called as a toy kit. We call it a toy kit. We have a toy kit for 0 to 2 years, 2 to 4 years, and 4 to 6 years. We call it the infant kit, the toddler kit, and the preschooler kit. And using that, we do this assessment to find out where a given child is. Such kits are available in our institute. You can outsource or buy them also. But you should not use force also. When you are assessing children, you can't force them to answer. You have to be in a very different mode. Don't label them. I find many mothers who come to me start off the first end. I think I have seen my child is having a ADD. She will start off, or she say he is having autism, or she is having a phobia. How did you come to know? I saw in the Google. So which means they are predisposed and prejudiced to their child, and they start by labeling the child. Please don't do that. Child has to be seen as a child, and don't start with any pre-assumptions about the child. And it's not also more about filling forms, because I find many people just wanting to fill the forms, get the files done, get and then it's not that. It's much more than that. And you have to differentiate between learning and perform. Many children know, but they may not perform. For example, a child might know 5 nursery rhymes, but a guest comes home, he or she will say only one, or he may say none. Can we assume that he is not learned anything? No. So for every activity, there is a distinction between learning and perform. Don't go by only performance, because learning to transfer into performance, motivation is required, rewards are required. So all conditions are there. The child may know a thing, but it may not be willing to perform. That's the point I'm saying. So plus the best performance must be taken, not the worst performance. Then you can make a correct, what do you call, assessment of a given child, developmental assessment. Children should be not in medication, drugged, tired. Here I have put some milestones for the convenience of students also. These are the major gross developmental milestone, which is normal. But beyond it, they are considered to be subnormal or abnormal. So next study, these are well known, so I need not waste too much time on this. But this is a point you should remember, development. Here are a few more examples which we often miss out, and it is there in our developmental tools. At turns head to a somersault. He's about to somersault, but he's not somersaulting. Then climbs chair. So I'll pass on this PPT to all of you if you want. Go through that. Slowly you will understand every activity as a, this what we have put in the brackets is not something very sacrosanct. It's not that exactly on 24th month birthday he will be doing that, or in the 30th month birthday he'll be doing that. If he doesn't do, he's having it. It's not like that. Variations are there, I understand. There are, but we keep this as a goalpost, we like a guideline. And for these activities, we see according to that. Emotional development. Often we ignore in our physical assessment of the children. Children also have a part of an emotion, from starting from general excitement to understanding difference between pleasure and pain to understanding finer emotion. So there are definite ages when all these emotions develop one after the other, until they learn fine-tuning the emotions, and they can even understand differences like envy, jealousy. Small kids may not understand, but there is the age and all this. So what is I'm explaining is emotions also have a age-graded development. We also have milestones in emotional development, which I was just saying. These are the major milestones. Joy at one age, pride at so-and-so age. So all these are very important for the assessor or the examiner to have an idea when you do a developmental assessment. Don't go by only physical assessment or motor development. Cognitive development. This is one area we generally ignore when we are doing developmental surveillance or screening. We have to see that children learn to track objects. First, they will have an object fixation. That is at birth and immediately thereafter. Then they will start tracking objects 3 to 6 months. Then they will develop object permanent. They know that the object exists even if I'm not there. So a toy or doll exists even if it is taken away from my eyesight. So that kind of object permanence is also important. So you won't find object permanence in very small children. And there are some children beyond 12 years, 1 year also have not developed object permanence. Then in such cases, you should be very much guarded. I have cases of children with autism, For example, they will not have object permanence at all, or they are very delayed. So you have to keep that as a risk point. There is a point when children will know here and now what is happening now. Then thereafter they can think of future. They can talk of the future, tomorrow, day after tomorrow. So you can't have children, small children, knowing a time frame of yesterday, today, tomorrow. But at one particular age, they will know. So these are all important cognitive, what I may say, milestones, which has to be checked for every child. We also check all these. So these I have given the socials, what do you call milestone, starting from smile, eye contact, joint attention means when two people are, suppose I show a bird on a branch to the child will look at the branch and the bird. But some children will not look at the bird or the branch, but they will look at your finger. So which means they are not having a joint attention. He is looking at the finger rather than the object you are pointing out. Now this is a very intricate thing. This sort of problems are there in some children. They don't understand body language. What is anger? What is sadness? When is the mother in a sad mood? So these also have to be understood. So if there are delays in this, be cautioned. Be ready to understand that. Play. Play is a very, very important, and developmental psychology we recognize. Play has got very many types, very many stages, very many steps. So you should know what stage a given child is in which play. Not all children are in the same stage. So play, for example, I've taken one example here, scribbling. Scribbling, we think children scribble just like that. Actually, we have discovered there are 10 to 12 stages in scribbling itself. Simply, there is the first stage when a child will simply hold all the pencil, paper, everything, keep it. You find small children at 1.5 years, they will hold everything and keep it with them from the elder brother or elder sibling. But they won't use anything. Simply, they will keep it with them. That's one stage called holding stage in scribbling. From there, then they will start banging to write the materials on board or paper. Then they are seeing the impressions. Then they will start scribbling. There also scribbling is random scribbling. Then there is a controlled scribbling. Then there is a clockwise scribbling, an anti-clockwise. So scribbling itself is one of the important areas we go deeply to see what is the developmental level of a child. Now, don't think scribbling is a waste of time, waste of energy or paper. It is a very important developmental activity. And if scribbling is affected, you must see that all these things are also taken into consideration. You must improve their grasp. You must teach them all these activities. You have to teach them how to unwrap candies, how to tie or untie knots, how to trace a palm. So these are the common developmental activities we prescribe for children who lag behind. So very important that the examiner also suggests such kind of activities. Now, what are the common scales? I am given here, due to shortage of time, some important tools for developmental assessment, which is Indian, for Indian, by Indian, and for our children. This I want to caution because many of us, we just follow the Western ones. We have an Indian version of the Bailey scales available. It's called the Fartex version. We have Kuhlman's infant rating scale Indian version. We have the Denver scale developed by Bharat Raj from Aish only. He has developed the developmental screening test, which is available with us. We have recently come up with the activity checklist for preschool children with developmental disability, and that is from the Department of Clinical Psychology, 0 to 6 years. It's available on the web also. You can download it for free. We have a portage guide for these children. We have Segwin form. These are the various lists of tests, totally Indian, and for the Indian children. All of them, I can assure you, they are well standardized. They have their own reliability, validity, sensitivity, everything is there. Now, what we do for very small children below 3 or 6 years, we use the term developmental age and developmental quotient. For children who are above 6, we call them as intelligence quotient or IQ. We don't use the word IQ for a 3-year or 2-year child. They are because that is development is going on. They can develop further. Whereas IQ is something more stable. You can't change an IQ of a child. You can improve the developmental quotient by stimulation. We also have adaptive skills for social development, what we call social intelligence. We have a formula for that. So then we have scales for that also. We are having Indian scales also for that. These are some of the tools. All these tools are not armchair preparations. They have to be standardized. They must have validity, which they have. And some of them should have good sensitivity also. Sensitivity, they must be able to correctly identify the problem. They must have prediction rates. All this is there in most of the scales I just mentioned. There should be inter-rater reliability, test raters reliability. All these are the norms which is given by American Psychological Association, and when you call it as a developmental screening test. Some red flags. What happens in development assessment is if you find children are not doing some things beyond that age, you must mark it and say there is some risk going on. There is a danger around the corner. The child requires a special training. I have written here, for example, 0 to 3 months, rolling over, persistent fisting, failure to startle for loud sounds. If you continue to see, then there is a risk that he may be hard of hearing, or he might be having a physical issue or something like that. So we have, these are the critical point which every assessment or examination must keep in mind whether the child is doing this. That's why I said this is a time-taking process. It requires literally sessions after sessions to do per child. If suppose 24 to 36 months, no eye-to-eye contact is there, then that means there is a risk there. No free play is observed. No peer play is observed at that age. Then that means there is some social dimension which is affected. Picture recognition. Usually at 36 months, children should recognize picture. And he cannot recognize picture. That means there is a problem there. So these are all what you may call as red flag. You must keep in mind. Find out the risky children. And if you find that, you must promote these activities. I've given quick some examples. Hearing and listening skills. We have a hearing and listening therapy activity in AISH where we give listening skill training, seeing skill training, pointing skill training. Many children are unaware of pointing. So what happens? How to point, how to gaze, how to look in a particular direction. All these activities have to be given a special encouragement in the early intervention program. Observation skills, where to observe, how to observe, when not to observe. Imitation. Some children below 3-6 years have not picked up imitation. They observe children, but they don't imitate. They cannot play like them. They cannot shout like them. They cannot run like them. So which means there is imitation is very, very laggard. So that indicates a problem. There is a stage when children will recognize their own belongings and others' belongings. A child has come to 3 years, but he cannot recognize his own belonging, others' belonging. Some child snatches his things and goes away, but he simply keeps quiet. He doesn't know he is taking away his thing. That's also a problem. Play. Many play activities require turn taking. A child is developed, but he doesn't know waiting for his turn, when to take turn. So these are all humor. Also, I have mentioned here. See, there are stages in humor. Every child, a small child's humor level of humor is different. A bigger child is different. An older adolescent is, an adult humor is different. So what level of humor? So the point is there is a development gradient even in the development of telling a joke, receiving a joke, understanding a joke, or a humor. Here are some more promotion activities I have quickly listed here. Something like discriminate. This is hot and cold. Children should know. Know means not only knowing and naming, but they should experientially also be able to sensorily discriminate shapes, circle, triangle, rectangle, or even now primary shapes, we can add a few more. All this should be known. They must know the different tastes. They must know to sort by size or colors. They must understand the difference between rough and smooth. You show a tactile rug and ask, where is rough, where is smooth? They should know that. They must learn to stand with balance. So in our list, which I said, the activity checklist, we have nearly 500 activities listed there for children below 6 years. It is like an inventory. It is like a checklist where the examiner can just sit and tick, can do, cannot do, can do, cannot do. If they cannot do, that becomes a indication of where the development is. Motor activities also you can promote by having activities like inserting money into a piggy box, or inserting key into a lock, or zipping or unzipping, folding an handkerchief or paper into four, lids of bottles are screwing and unscrewing. So like this, we have also promotional activities for less than 3-year children, depending on what is their assessed developmental level. The recommendation is after the developmental assessment, you should go by their developmental age, not by their physical age. You should appreciate the individual differences. There are many instances I come across where children have not been given an opportunity to talk. Can he cut with scissors? The parents say, no, we never give him scissors. Can he light a candle? I ask a 4 or 5 year child. Then the parents say, no, we have never given an opportunity to light a candle. So which means no opportunity issues also may be there why children are laggard. All these activities should be done in a play way, in an informal way. And it should be paced according to the child, not according to the adult. So parents, I find, they go by their speed, their expectation, not according to the speed of the child. That's why I want to add last word on parenting. We have nowadays new forms of parenting emerging. One is, especially in the urban area, hyper parenting, where parents are inadvertently overscheduling. They keep a lot of activity. They overfill the timetable of the child. So much so, the child has no time to breathe also. This is one extreme. Another extreme is hypo-parenting, where children don't even bother about this. What is happening? How is the child developing? What is happening? Where is he going? So we have parenting issues also which come in the developmental assessment. So a child who is optimally parented will have the best of the developments. Helicopter parenting is one thing commonly coming up now, where the parent is always hovering on the top of the child. What is he doing? Where is he doing? What is he touching? Where don't do that, do that. No. You find a lot of parents behind the child. So parenting is a very, very key element in child development, especially during early years. People have got a lot of money now. Affluenza, that's what I mentioned there. Lot of money, lot of everything, but they don't have quality time with the child. With infants, toddlers. So what is required is a quality time. And that is what I am talking about in this time, where children have to be given important time. So for short of time, I've given to an overall glimpse of what all is happening in developmental assessment. And that too, from my clinical point of view, I have tried to emphasize more than from a textbook point of view or a theory point of view, because this is what we experience here. And if you also come across such children where there is a developmental lag, there is a variation, get it done, get the examination done professionally. Don't do it arbitrarily. Refer them to institutions where they do this and get a report, keep the track of it, and then it will help the child, the parent, and the whole system. So to conclude, let me also say, your child's mental health is more important than their grades. Let them be little, let them be creative, let them play often, and in short, let them be children. That's my message. Thank you very much for listening. And if there are any questions which I could not cover because of short of time, because 45 minutes is something too short to compress so many things. So you are welcome to ask questions. Please go ahead. You have another 10 minutes or 5 minutes, I guess. Thank you so much.
So thank you very much, sir, for a very comprehensive and in-depth presentation. So there were a few questions on the chat box. Some of the delegates want to know what are the EQ scales that is available, sir.
Pardon, repeat. What are the?
Yes, sir.
You repeat that. What did you say? What are the?
Which are the EQ assessment scales that are available for Indian children?
EQ we have EQ separately. We do not have scales. We have EQ, or don't call it EQ. Emotional component. Emotional components are assessed as part of the social component. We have something called as social adaptive behavior scales. Social adaptive behavior scales, which have one of the components as emotion, because social emotion comes hand in hand, and we find that emotional component is embedded in the social scale. Some of the important scales we have is the Vineland Social Maturity Scale. Vineland Social Maturity Scale, where you can find out the emotional component of the, but exclusively talking of EQ for a small child as you do for adults may not be apt, because their emotion is embedded with social development, play development, and all that.
So the next question is, are the baby products safe for neonates and infants?
Which baby product? Market products? No. He would not recommend. Anyway, I'm not an expert on baby product, but still, I guess what is required is homemade. I will talk here toys. You don't require very healthy. I'm not talking of baby products. I'm talking of toys. There is a huge echo coming in. I think you are
concluding session.
I think 2 mics are on or off. There's an echo I can see. Please reduce the echo. Okay. So talking of, no, still it is there. Sound echo, please. Okay, now I'll try. Now it's better. So what I was trying to tell you is, more than food products, I'm more worried about the toys. Nowadays, market is flooded with so many types of expensive Chinese or ready-made toys. Children don't really require all that ready-made, costly, expensive toys and all. What they required is homemade activities and homemade work also. And of course, baby products, talking of, there are also a lot of misconceptions people have that you should have GFCF diet, or you should not have that, you should not give wheat, or you should stop milk. We, as development psychologists, don't believe in so much of that. What children require is an optimum nutrition, plus a lot of activity-based teaching, play-based teaching, individually tuned teaching, one-to-one for smaller children, small group activity for little older children, bigger group activity for the still older children. All that is optimally stimulated, they will come up very well in their development.
So the next question is, they want the address for procuring the scales, sir.
The address is our website. Come to Mysore.in is the website, universal website. Go to the Google and you can contact us. Some are available in the institute, or some are available with the sellers of psychological tests. So private sellers are there. Some we have outsourced and they are selling. Quite a few, like the toy kit I mentioned, is available at ICE. The toy kit manual is available at ICE. But there are some other tests like a Gesell drawing test is there that is available outside in a private company. So some we have outsourced to the manufacturers of psychological tests. Some we have developed ourselves and we are giving for. Some are nominally rated, some are free also. You can visit our website, aishmysore.in, and you will get an idea. Visit the psychology department, you will get an idea of what are the things available with us. If you still have any doubts, you can always post an email to us and we can answer individual questions about buying or selling or availability of this.
So some of the delegates want to know if online training on developmental assessment is being offered.
For who?
Online
For the
training on
examiners or
development.
no, we do online assessment of children for developmental. What is currently happening in the corona periods in the last few months is we have a tele mode of assessment, which we have stopped. Earlier, we were doing face to face. Now, ever since corona came up, we are doing regularly tele mode of developmental assessment for children. We visit their homes, we visit their parent, we talk to them on the tele mode, and in a virtual mode, all the tele assessment is being done for various safety reasons. But as of now, no training program per se is given for professionals. That you have to start doing anything like that. But we do tele assessment of children by involving them. But actually, more ideal would be to do a face to face. It should be we should have, as we were doing earlier, you should be doing it in a face-to-face mode. How can you do tele-assessment with a small baby or a small child? But we have to do it through the mother or through the parents or through the teacher. So in that way we are doing. Now we are having a challenging time. But otherwise, ideally speaking, it should be done. And we frequently conduct workshops. You can have a look at the website again. Small time workshops are there, webinars are going on. How to do daily assessment or how to do development lesson. If you attend that, you can get to know how to. For example, the activity checklist is how to use that tool to do a developmental assessment. So you will be doing that. You can have a look at the website to see when such workshops are running. They are short-term courses, refresher courses, in-services courses. So you are welcome to attend them. That you can have a look at the website regularly.
So the next question is how to develop interest in eating for a child below 2 years of age.
Is the child having a problem or the mother having a problem? If I ask this question is, most often eating problems when children are brought to me, I find there's a huge issue with the parents. The child is either fed. See, in feeding children, there is something called as timed feeding and spaced feeding or child wanting to be fed. Most mothers, I agree, I see here, they have fixed time. They have a fixed quantity. They have a fixed everything. They want their work to be done. So they say this much has to be fed. This is the time it has to be fed. So they have feeding is become a ritual for them. And the job is to be, I'm not blaming the mother. And they are doing their best, I know. But what happens, the child may not be hungry at all. Sometimes our special children, they would not have had enough activity to be feeling hungry. In between, they would have had a lot of short eats. They would have had some extra eats. And again, your time comes, you'll have to feed them and you feel tense. You will convey that anxiety to the child. You will shout at them, hint at them, scold them. You want them to do. So that eating becomes more than a pleasurable activity, a painful activity for the child. So please examine. What you are raised is a behavioral problem. Behavioral problem originating from the caregiver than the caretaking child. So the child becomes what happens the moment the mummy comes with the bowl in front of him, it's an alarm bell for him to start shouting. On the other hand, if the same mother comes with the chips packet or something to do with the pizza, he's very happy. What does it mean? How will the child be so happy with something, a short eat or a chocolate or biscuit, but you bring your traditional food to the... So which means the eating has become a ritual Eating has become a forced activity. Please do not force feed the children. Only when they are hungry, you feed them. Don't fill them up with unwanted junk. These are something, and you have to give them enough activity to digest the food also. Especially urban parents and urban children, my point is there's no enough activity. They don't do to expend that energy. And especially children with special needs, they are stuck in one place. Where is the expenditure of that food energy? So what happens? They will not have anything. So again, next time has come to eat again. Again, by the time they spend that, they're again into eating more. So I think the child must really feel hungry also to eat. That is the eating problems are more to do. And you find there are also instances nowadays I am seeing youngsters, teenagers, not children, who are having anorexia. It's a growing problem in India. Anorexia nervosa means where young 10th, 9th class girls and all, they want to slim, they want to look trim, so they stop eating. They will diet to such an extreme that they will become an anorexic. Opposite is obesity. Obesity in babies, children, and infants is another growing problem in our country. Too much of uh, feeding or overfeeding or whatever wrong faulty feeding, they're all turning into obesity. No physical activity. They all become TV, what do you call, buffs. They'll simply sedentary activity. So I guess there should be optimum physical activity and food and feeding and also should. And you should let the child also pick up and eat on his own. You running behind him, there was a time when a mother used to sit in one place, the child will come to the mother and get the mouthful feed and go run. But now I find the mothers running behind the children and the children are being fed that. So a lot of difference between you running behind the child and the child running behind you for food. I think these are the results of some feeding problems in contemporary times, especially in urban areas.
So the
Have a
last,
thought on that.
so the last
Yes.
question is, what is the age appropriate for early intervention program for children who are premature?
There is no age of the first. The day you identify is the first. The day you get to know, there's no time to be wasted. Every moment is precious. Every second is precious. You must start the moment you come to know there is a risk there, you should start. And early intervention is there's no cutoff time or anything. You start the moment you get to know. But you should have an exact assessment done, correct assessment done, which are the pluses and minuses, where are the highs and lows, which behaviors are better off, which behaviors are less, where no opportunities are being given. The correct profiling is what is required. Once the development profile is accurately done, then you can start. And it should be done in a technical way, in a guided way. Activities are there, but you should have correct profiling. That's what I am repeatedly saying. Behavioral profiling of every child is very important. Behavioral profiling is nothing but what all they can do, what they cannot do. What have they been given opportunity to, what they, and what they are not. You start from the day you know. There's no muhurta time illalke. Any time is a good time for that. And children should be optimally stimulated. If they don't, you are losing precious time. But don't fill up them with too many things. That is also dangerous. Don't overfill them, neither understimulate. And it should be released by the child, not as a matter of force, not as a matter of ritual. Children should enjoy whatever activities. Then the development will start happening. But it should be done regularly also. And actually, these are the things we tailor make for each parent and give. When they come here, the high risk children, we make a tailor made program. We have a team actually, it's not a psychologist alone. We have a occupational therapist with us. We also have a nutritionist with us. We have a speech pathologist, audiologist, ENT, all the departments we work together as a team and work out and make this profile and infant development happens in that. It's a group work, teamwork.
So thank you once again, sir,
Yes.
for your effective presentation. I will just sum up sir's presentation. The quote by Maria Montessori, that development is a series of rebirths, which clearly signifies that every stage brings in a set of challenges for the growing child. Sir also highlighted on the principles of development, importance of developmental assessment, screening, monitoring, surveillance, and not to forget the follow-up. Methods used like baby diaries or records, high-risk registers for deaf children and blind children, the importance of developmental milestones, especially history taking and the indicators for children with cerebral palsy, hearing impaired, intellectual disabilities will be very useful in the long run. Conditions for developmental assessment with special reference to play-based method was very informative. How important it is to support the child's emotional, cognitive, and social development is was also equally highlighted in Sir's presentation. The hoarding stage, that is the significance of encouraging the child to scribble or do whatever he or she is interested, is very important in promoting the child's mental activity, was also another special reference made by Sir. Sir also touched upon the various engine tools that are being made available for the proper and in-depth assessment, and how important it is to focus on red flags with a very close observation, and promotion of social play through social skills like listening, seeing, pointing, imitating, observation, turn taking, greeting, and not to miss the significance of humor, and activities like sorting, motor activities, recommendations, how it needs to be given for based on the developmental age and not on the physical age was also highlighted. Last but not the least is the importance of parenting with special reference to hyperparenting, latchkey parenting, helicopter parenting, and the need for quality time that should be given from the parents to the young child is the need of the hour. With this, I extend my sincere and heartfelt thanks to you, sir, and I also thank the organizer for giving me an opportunity to moderate the session. Thank you so much, everyone.
Me too. Thank you very much, the organizers. Thank you, ma'am, for excellent moderation. Thank you all.
Thank you, Dr. Venkat Lakshmi ma'am, for moderating the session. Well, we have reached the end of today's national webinar on challenges of neonatal care and infant protection, organized by Human Development Wing of Department of Studies in Food Science and Nutrition, University of Mysore, Mysuru. I request Professor Asna Uruj, Chairperson, Department of Studies in Food Science and Nutrition, and Professor Komala M, Webinar Convener, to occupy the chairs on the dais.
Concluding.
Now I request Professor Komala M. I request Professor Asna Uruj to give her views.
Give me the program. Very good afternoon to one and all. How soon the second day is over, and we have come to the end of the national webinar, which was organized to discuss very important and pertinent issues like what are the challenges we are facing, particularly in India in neonatal care and taking care of the infants. We had a good array of speakers who were, drawn from medical colleges and the Breastfeeding Promotion Network of India and pediatricians, and also from clinical psychology, All India Institute of Speech and Hearing, and also Professor Jamna Prakash, who had who mentioned about the nutritional intervention. And everywhere, what I have observed is like all the speakers have emphasized about the importance of proper nutrition, whether it is prenatal duration or postnatal or antenatal. At every stage of life, appropriate nutrition plays a very important role, and more so in case of premature, children with, infants born with low birth weight or born before term. If they don't, as such, they would have missed many milestones, and if they are also facing many imbalanced, if they are getting imbalanced nutrition, then it will further aggravate their condition, especially their growth and development will be hampered. I think we have got rich insights from all the specialist speakers, and they are all specialists in their own area, and all of them have given us a very simple and easy to understand and take home message. What is most important is to implement these. Now, whose responsibility is it to implement this? We cannot sit back and say it is the government who has to do it. No, government will not come. Now, from among the participants, how many of us think that it is our personal responsibility to follow or implement? That is most important. Whether it is a male or a female. See, every male is invariably going to be a parent, a father. A female also will become a mother, isn't it? So therefore, it becomes each one of us is responsibility to see to it that we take good care of the mother before, and it is the responsibility of the parents also to see that their teenage daughters are not married off and then they don't face these circumstances. So that is one way where we can overcome to some extent. Then besides that, the couple themselves have to have an understanding and see that the women should not be anemic, and she should not be underweight, and she should not be suffering from any health issues, and only then they should go ahead and plan the child. So this is very important. And during the pregnancy stage also, care should be taken, but over care also can lead to excess amassment of weight during the pregnancy period, which the woman will find it very difficult to shed off post delivery. So there are many issues, and I personally feel that it is each one of us, and events like this will give us opportunity to understand what is actually happening in the field of pediatrics and medicine. So I think the event has been very successful in making us enlighten about all these current aspects in case of neonatal and infant protection and care. So I hope all the participants have benefited from the 6 deliberations we had from yesterday and today. Thank you so much.
Thank you, ma'am, for your support. Now, I request Professor Komala M, webinar convener, to present the concluding remarks and render vote of thanks.
Good afternoon to all. We have reached the end of today's national webinar, Challenges of Neonatal Care and Infant Protection. It is my earnest duty to provide some concluding remark, as well as it is my great pleasure that to propose vote of thanks. It was a challenging task, especially for an organizer, to assemble the eminent people from the different field and parts of the country to ponder on the challenges of neonatal care and infant protection. I outrightly state that this webinar has been an outstanding illustration, especially participation's mind have been assailed by a surge of ideas, information, statistics, interpretation, visions, and it will probably a day or two before we can sift through them all the consolidated our own personal perspectives. There is indeed a plenty to reflect upon, and if this is any way enhances our individual or of collective contributions to meeting the challenges of neonatal care and infant protection, then the seminar can truly be adjudged a success. With a glimpse of webinar, I would like to present a concluding remark. The two-day National Webinar on Challenges of Neonatal Care and Infant Protection was inaugurated by Professor G. Hemant Kumar, the Honorable Vice Chancellor of University of Mysore. In his inaugural address, the Vice Chancellor clearly highlighted the situation of neonates in global and Indian context. He states that it is appreciable to note a decline in a neonatal mortality rate in India, but it is at slow rate. He stated the quality of life of the children during the postnatal period is of highest concern in today's world, mainly due to both the immediate and the long-term outcome. Poor nutrition is especially the first 1,000 days of a child's life can also lead to stunted growth, and it is associated with impaired cognitive abilities and reduced school performance or of work performance. The Vice Chancellor emphasized the importance of developmental screening in India needs to be prioritized as a preventive strategy. The webinar convener extended the welcome to all and introduced the theme of the webinar to the audience. Professor Asnauru, Chairperson of DOS in Food Science and Nutrition, University of Mysore, stressed on the role of pediatricians, nutritionists, and other health professionals, especially in prevention and management of neonatal care, and extended the vote of thanks in the inaugural session. So inaugural session was followed by the scientific sessions. The total of 6 scientific sessions of the webinar focused on different issues related to the neonatal care and infant protection. The first scientific session focused on essential newborn care by the resource person, Dr. Mallikarjun, professor and pediatrician, MS Ramaya Medical College, Bangalore, and moderated by Dr. Arokya Amarai Chelvi, associate professor from Avinash Lingam University. Dr. Mallikarjun spoke on extensively, especially covering the minute details of newborn care. He spoke on the essentialities of caring a newborn, the deliberation on daily routine care, benefits of newborn care, do's, don'ts on feeding practices, importance of mother and the child relation, harmful traditional practices, danger signs of newborn, had enhanced the knowledge of participants or of listeners of this webinar. Even certain queries with reference to the care of premature babies and baby born with the cesarean section were also clarified in that session. The second scientific session focused on the breastfeeding current practices, policies, programs by the resource person, Dr. Arun Gupta, Central Coordinator, Breastfeeding Promotion Network of India, Regional Coordinator, IBFA in South Asia, New Delhi. Dr. Shobhaji, Associate Professor from the VHT, Central Institute of Home Science, has taken up the moderate work. So Dr. Gupta spoke his speech especially helped the participants to understand the importance of breastfeeding, the policies and the programs in India. His talk covered about early and exclusive breastfeeding, how it plays a key role in the prevention of newborn infection and premature death. His talk provided an insight on the component involved with essential newborn care, identification of illness, even at risk condition, how to manage them. Dr. Gupta also detailed on the statistics related with the risk of neonatal mortality, according to the time of initiation of breastfeeding. This would help the community health professionals, nutritionists, for framing the guidelines on initiation of breastfeeding. He also gave a broad outline on the impact of inadequate breastfeeding and how it can impact the child's as well as of mother's health. He also spoke about the various state policies in the programs that have been implemented for supporting the health and well-being of women. His talk presented a wide understanding on the steps for initiating the successful breastfeeding, boosting the breastfeeding, reducing the consumption of unhealthy diet, especially the infant feeding. The speaker also shared most useful information on policies and legal matter related to baby food, which is indeed a very good message for understanding do's and don'ts associated with the baby care. The third scientific session focused on the early nutritional intervention for infants and young children by Professor Jamuna Prakash, former faculty, Department of Food Science and Nutrition, University of Mysore. The session was moderated by Dr. Anita C. from KSOU Mysore. Professor Jamuna Prakash gave a detailed information highlighting the importance of early nutrition intervention, since it is considered as one of the most significant determinant of development, functions, and future health of all organ systems and major factor in both risk and the prevention of non-communicable diseases. She also briefed on the aspect such as nutritional, metabolic factors acting during the sensitive time period of developmental plasticity before the birth or after child's birth, directly or of indirectly causes of malnutrition and consequences of deviation, especially the growth and development. Professor Jamuna Prakash also elaborated on the essential nutrition action to be implemented at a sensitive period of growth for minimizing the associated risk factors like consequences. And this particular session helped to gain the knowledge pertaining to early growth nutrition care of having a better health outcome in future years. So she also shared the important key messages for improving the nutrition around the life course for early nutritional intervention, and she stressed on the importance of immediate initiation of breastfeeding after the birth. She has highlighted the importance of breastfeeding on complementary foods for proper nourishment of young children. Her talk also included a dietary guidelines for different stages of life cycle, such as school-age children, adolescents. Further, the guidelines were also extended to the pre-pregnancy and pregnancy stage, since the nutritional care plays a central role in the growth and development and sets the stage for better nutrition in future years also. So on the whole, the talk was very extensive and informative in terms of stressing the information related to the importance of early life nutrition, as it is regarded as the most important central determinant of both lifespan and of health span. On the second day of the webinar, 6 scientific sessions were held. The fourth scientific session was on the management of preterm and low birth weight babies by Dr. Sudha Rudrappa, Professor and Head of the Department of Pediatrics, Mysore Medical College, Mysore. Dr. Sudha Rudrappa's presentation covered the vast issues related to the preterm and low birth weight babies, namely incidences, causative factors, risk factors, care of preterm babies, low birth weight babies, monitoring, early detection of complication, feeding regimes, especially focusing on low birth weight babies, which is relatively difficult. And also, like, she touched on the enteral feeding, principles of advancing feeding mode, supplementation and fortification, and she emphasized on the Kangaroo mother care, so preterm complication screening. She also spoke about the pathways, multiple pathways, which leads to low birth weight or premature birth and its prevention. She also emphasized on how the babies with a different birth weight terms of birth requires a different kind of scientific inquiry and clinical strategies. And she concluded her session by stressing on the fact that how this condition encompasses a wide array of measurement, system, and clinical intervention across the healthcare system, and even many healthcare disciplines which are yet to take hold in Indian healthcare system. The fifth scientific session focused on health indicators of neonates and infants by Dr. Kuldeep Singh, Professor and Dean of Academics, HOD of Pediatrics, AIMS, Jodhpur. Dr. Kuldeep Singh Sir enlightened us about the health indicators of neonates and infants. The entire session mainly focused on the challenges of the perinatal mortality and the importance of care that has to be given during the period. Indicators as measured to assess the health and the ways for achieving the goal of good health using health indicator. He also briefed us about the various health indicators such as inputs and output process, outcomes, impact indicators, which are generally used in healthcare system. He also deliberated on the significance of health indicators and how they could be used as a tool for improvising the community health as well as of universal health coverage. How these health indicators are vital in planning a life-saving intervention such as quality care, managing infection, and the personal hygiene both for the mother and the child. His talk also mentioned about the health status of Indian infants, burden of neonatal death rate, infant mortality rate, indicators that could be used to check them. Overall, the speaker gave an in-depth information on the indicators of health and how well they could be used towards strategizing intervention to prevent mortality and death rate for promoting long-term health benefits. The sixth scientific session was on the infant growth monitoring, screening, and surveillance by Dr. S. Venkatesan, Professor and HOD of the Department of Clinical Psychology, All India Institute of Speech and Hearing, Mysore. Dr. Venkat Lakshmi, Associate Professor of VHT Central Institute of Home Science, moderated the session. Dr. Venkatesan's talk covered extensively about the basics of infants and child development, the principles of development, and its indicator. Sir also shared the information on monitoring, screening, and surveillance and follow-up. His talk also covered the importance of delivering the care, especially for the specially abled, like visually impaired, hearing impaired, and even the developmentally challenged, like cerebral palsy, autism, and all that points he has touched. He also spoke about the important developmental assessment tools used and accepted standards for India. Further, the sir added on some of the red flags from the developmental assessment kind of promotional activities that could be adapted as a measure for improving the development, focusing mainly on the cognition and motor activity of the children with various abilities, special abilities. The talk also covered explicitly about the parenting and how they can impact on child's growth and development. And the speaker concluded by saying the child's mental health is more important and the parents should allow them to be creative and allow them to play often for encouraging various aspects of development. From the above presentation, I'd like to conclude that challenges of neonatal care and infant protection is not a simple issue. Even many webinars can be conducted focusing on the different disciplines and the perspective. There is a vital need to adopt a comprehensive, holistic, and intervention approach to have a better insight for prevention and management of newborn complication, which can otherwise prove fatal, not only to that particular individual, even to the next generation. So with this concluding remark, even I would like to extend a vote of thanks. It gives me an immense pleasure to extend earnest vote of thanks to all associated with this webinar. The first and the foremost, I extend vote of thanks to all the resource person of this national webinar, Dr. Mallikarjun, Professor of Pediatrics, MS Ramaiah Medical College, Dr. Arun Gupta from Breastfeeding Promotion Network of India, Professor Jamuna Prakash, former faculty of Department of Food Science and Nutrition, Dr. Sudha Rudrappa, Professor and HOD of Department of Pediatrics, Dr. Kuldeep Singh, Professor and Dean of Academics from AIMS Jodhpur, Professor Venkatesan, HOD from the Department of Clinical Psychology, Aish. Even with their very busy schedule, they are very kind enough to accept our invitation and they've highlighted the critical issues that are need to be addressed. We are fortunate to have them as a resource persons of this webinar on behalf of the department, University of Mysore, and on my personal behalf, I extend a sincere thanks to all the resource persons. I wholeheartedly extend my thanks to my colleagues from the other universities, Dr. Arokya Marai Chelvi, Dr. Ramya Bhaskar, Dr. Shobhaji, Dr. Venkat Lakshmi, Dr. Anita C, for their support and cooperation extended to us in moderating the scientific session. Since this webinar is organized as an event of Golden Jubilee of the Department of Food Science and Nutrition, I express a gratitude to all former faculties, members of this department, Professor Padma Umapati, Professor Rudrama, Professor Saraswati Ji, Professor Shashikala Putraj, Professor Kainuriza Begum, Professor Jamuna Prakash. The chairperson of the department, Professor Asna Uruj, found to be a great leader, upright organizer, and always be supportive and encouraging in organizing academic events. I extend my heartfelt thanks to Professor Asna Uruj for her support and encouragement. I sincerely thank all registered delegates, participants of this webinar. I must mention that more than 540 people registered for this webinar from in and around the state, as well as the few of them were registered from the foreign countries. On the first day, I could able to see that nearly 200 participants were linked. More than 200 participants were linked. On the second day, it was 150 to 170 delegates being linked. I thank all the delegates for their participation. The authorities of the University of Mysore also deserves our gratitude and thanks. All kind of facilities, including the financial support extended by the University of Mysore. I am very much thankful to the authorities of University of Mysore. It is very important that views expressed by the speakers are to be disseminated to a wider readership or of audience. And clearly this task has been in a very capable hands of ICD and IOE people. So I extend my sincere thanks to technical persons from ICD and IOE of University of Mysore for their technical support and to provide the auditorium for this webinar. I cannot fail to thank our hosts, whose contribution is highly valued. I am grateful to all those who have been involved in the organization of this event. While there are too many or of numerous to name individually, I'd like to express my deep appreciation and the thanks to all guest faculty members, research scholars, non-teaching staff members of the department who sincerely committed to this event to make it a grand success. This webinar is effectively conducted with the support of each and everyone in the department. The last but not the least, I greatly appreciate the support we have received from the members of media in covering our activities. Since the department is celebrating the Golden Jubilee throughout the academic year of 2020-21, we look forward to seeing you all, the delegates, again in the near future. Then we shall reconvene to discuss another theme affecting the quality of life of human being from the developmental perspective or of health and nutritional perspective. So I thank one and all. So we close the webinar with a warm wishes. Stay safe and be negative with the COVID situation. Thank you one and all.
Thank you. Okay. Now we host.